is not influenza for which Tamiflu is useful, this is another bug like human metapneumovirus, in which case you let the patient go along, manage the symptoms. If they are dehydrated, rehydrate. If they are fever, sort out the fever, and so on, and wait it out, because the patient will get better. And this helps us with antibiotic or antimicrobial stewardship. Another group of patients who really suffer are the ICU patients. This is because ICUs are full of bugs which are highly resistant and therefore very difficult to manage. The other thing with ICU infections is that patients are already on 1, 2, or more antibiotics by the time you decide to manage them, or by the time they come to you. So you may do all your cultures and you grow nothing. And yet you can see a nice going lobe or pneumonia there. Which germ is that? Or you can see a pneumonia which is multilobar or having nodular pattern or ground glass, all those appearances. How do you decide what to give this patient? And you do not have time. In the ICU, every minute counts. In fact, a study was shown that if you give the wrong antibiotic, you lose 7% of the patients every hour. So it is very, very important that we have a way in which we can diagnose patients early and give the appropriate antibiotics to reduce morbidity. What's the burden of these diseases? And there was a study done a few years back. This was a Kenyan study done in the Kakuma refugee camp. I hope it is clear. And you can see that there are very many viruses which cause upper respiratory tract infection. And in this study, they found that most of these patients who came in with upper respiratory tract infection symptoms were on an antibiotic, while indeed it's only a small minority who required antibiotics. Things like influenza, other types of things like respiratory syncytial virus, those ones you don't need to give antibiotics. Influenza, you do need to give an anti-influenza medication, but for majority of those patients, they do not need antibiotics. Remember, if you are working in a place like Kakuma, you want to use your resources as well as possible. So you do not want to waste antibiotics on a person in whom it will not be useful. This also applies in our circumstances. Vile taxes ziko, hutaki kutumia pesa, mahali haitakusaidia. So very, very important that we treat our patients in the right way. There was also another study done in Kilifi, which showed similar numbers, that more than 50% of patients who presented to the outpatient had upper respiratory tract infection. So it's a fairly huge burden. And if all these patients are going to receive antibiotics, you can see just how much we are driving antibiotic misuse. When we look at the ICU, which is another critical area, you will notice that viruses which have been thought not to be so prominent also contribute to the burden of diseases within the ICU. Another important aspect in ICU is the presence of drug resistance. And the good thing with the Biofire system is that it is able to give you at least the most common resistance patterns so that you can select your antibiotic in a better way. Dr. Navid did a study at the Kenyatta National Hospital, and he looked at patients in the ICU and the type of infections that they had. He looked at day 1 and he looked at later after a few days in the admission. And you'll notice that 30% of the patients presenting to the Kenyatta National Hospital had an upper ventilator-associated pneumonia. This was done after a few days. And if you look at the first, I don't know if this will show. Oh, I'm not being projected. Sorry. Oh. Yeah, this is where I wanted to show. So, at the beginning of admission, yeah, this is the right one. You'll see that majority of the patients had respiratory tract infection, not upper, but respiratory tract infection. And even as their stay in the ICU went on, 30% of them had ventilator-associated pneumonia. The denominator is all patients who developed an infection in the ICU. So 30% of the patients who had an infection were having a ventilator-associated pneumonia. Therefore, this shows that the burden of these infections is very high, and many of these infections will lead to death. The challenges we have had is making the right diagnosis and making the diagnosis early. If we send a sample, for instance, we send sputum or we send bronchial wash for culture, the earliest we get an indication of growth is maybe between around 48 hours. And in most cases, to get an identification and sensitivity of the bug, you sometimes have to wait up to 5 days, just for the issue of bacteria. This delays starting the right antibiotic. And that is why many times with the dictum that hit hard, hit early, especially in patients with severe sepsis or septic shock, you may find that a patient with a regular run-of-the-mill, non-resistant bug ends up getting a very high-level antibiotic. And especially if your laboratory does not support you well, you may find the patient finishes with that course, and maybe they needed a much simpler, less expensive antibiotic. If we look at how history has been as far as disease infection diagnosis has come up, in 1600, Janssen invented a microscope. This guy was an ophthalmologist somewhere in Germany. Later on, a fellow called Hooke, it's an interesting one. He went to a nearby pond, scooped some water from the pond, and put a drop of that water in a modified, very simple single lens microscope. And he saw a brand new world under the lens. So after the discovery of this microscope, many different microbes were described. And later on, Laennec now made the stethoscope. This is just for your historical knowledge. Pasteur is very famous because he's the first fellow who developed culture medium. And then penicillin was discovered just last century. And then in 1980s, about 40 years ago now, the PCR was made. So what is PCR? Essentially what happens with PCR, it's a machine which generates many copies of a certain detected DNA or RNA. And this reaction is able, therefore, to allow us to detect what are the specific DNA fragments available in whatever solution we have presented. And this also allows us to study this DNA better in terms of what are the resistance patterns, and so we can get a better prediction of how the source of that DNA is likely to behave once exposed to certain antibiotics. PCR tests are very, very useful, especially in those germs which are difficult to culture. You see viruses, mycoplasma, chlamydia, all those are difficult to culture, and they usually cause what we call atypical pneumonia, which are difficult to diagnose in terms of etiology, and so the PCR tests are very, very useful. And the Biofire system is very useful because within about an hour or 2 hours, depending on the system you have, you are able to even detect these kind of difficult to grow germs. Let us look now at acute respiratory infections. And the way I would like us to look at it is by symptoms. For instance, if a person comes to you with a headache, which is a very common symptom of a upper respiratory tract infection, it will be very difficult to know why this fellow has a headache. Is it that he has meningitis? Is it just stress headache? Is it migraine? So the differential diagnosis is very large. Similarly, especially in our circumstances, if someone comes with a fever, is it an infection? Is it a non-infectious cause of fever? All these things go through a physician's mind as we decide how are we going to manage this patient. And all the other symptoms are the same. Someone comes with rhinorrhea. Is this infectious rhinorrhea? Or is it non-infectious, as can happen with allergic rhinitis? All these things go through our minds. So if we have a tool which will help us determine there's no infection here, you better spend your money giving some other form of treatment. It would really save the patient's time as well as improve the outcomes of the patient. And this goes on even for things like cough. One has to ask themselves, is this a cough due to an infection? Is this a cough due to non-infectious? And if it is an infection, is it a virus? Is it a bacteria? Is it a fungus? What is it? Is it a parasite? What is it? So if you have a test which allows you to detect these different possible etiological causes, then your choice of therapy will so much improve. The way we have been diagnosing respiratory tract infection for the longest is doing a history where you pick all the symptoms, then you do an exam, you pick the signs. Sometimes there are no signs at all. For instance, if someone comes with influenza, there may be no signs at all, but the patient is miserable. At the time they are presenting, they may not even have a fever, but they are very, very miserable. So you will find that just taking a history gives you half the story. You examine, you get another fraction of the story, but if you are able to do a test which gives you a real etiologic cause, then your intervention will be so much better. And the same applies also to pneumonia. You ask a patient, you are coughing, yes. You do an x-ray, you find a patch there on the x-ray. You have to ask yourself, is this a virus? Is this a bacteria? And many times you have been stumped where you can swear that this is tuberculosis on the x-ray. But then you do your tests and shock on you. You discover, oh, maybe it was a virus or maybe it was a parasite. And you are shocked because many, many patients have been started on anti-TB medicines while indeed they did not have that. So tools like the Biofire are very, very useful in this scenario. So I will not spend a lot of time because I know there is an expert who will talk about how these things run later in the day. What I would want to show you is that the number of bugs which this test can pick is very, very wide. And more importantly, it has targeted the most common bugs. So if you get one of these, then you know you are home and dry. If you don't get one of these, then your field of evaluation is quite narrowed. Now you can focus on other less common things. And the other good thing is that you get your results very fast. Within about 45 minutes in a good lab, you'll have your answer back and you'll be able to move to the other step. The same applies to the pneumonia Biofire, which also has most of the common germs. There are a few important ones which we have requested that they be included in future iterations. For example, pneumocystis in our circumstances, because we get pneumocystis especially in HIV patients, as well as patients immunosuppressed by other things. Stenotrophomonas, which is becoming a more common bug in the ICUs, amongst some other few, which if the company would check, then we would get even better at this. One of the drawbacks of this is deciding that whatever I've detected on the Biofire is actually causing disease. Sometimes it's oversensitive, and therefore using a clinical and other labs is very, very important to decide, should I treat this bug which you have picked in this patient, or this is just a red herring which is not causing disease in this patient. We have to also remember what is going on in the world. Just 2 or 3 days, I got about 4 phone calls in one day asking me, is there an upsurge of COVID? I think it was in one of the dailies. And it is quite accurate as far the Biofire is quite accurate as far as detecting COVID infection. And indeed, if I have a hospitalized patient who is able to afford the test, and they have an atypical pneumonia, I look at the scan and I think this is a viral pneumonia, I would rather request for a Biofire rather than a single COVID test, maybe antigen or PCR, because if I don't get COVID, the Biofire will tell me what else it could be. Just yesterday, I discharged a gentleman whom I had admitted with an atypical picture. He was very scared it was COVID. he had done a COVID antigen somewhere else, he did not, it was negative, and he did not believe it because someone had seen the x-ray and told him this is likely to be COVID. So when we did a biofire, and I told him, my friend, you have human metapneumovirus, he was first surprised. What is that? It doesn't sound like anything I know. But when I told him it is something self-limiting, which you clear by itself, he actually demanded for discharge immediately. So these things have a direct economic value. This guy was not willing to go home until you tell him what was going on. But the moment you gave him an answer, and that answer came within about 2 hours, the patient was very happy to go home, and we know he's not in danger. And the COVID test in this particular case was negative. The Biofire is also very important in ICUs. Remember, even if we send a culture in ICU, this patient may have received very many antibiotics, and they may not grow anything. Sometimes when they don't grow anything, you are left wondering, is this picture really pneumonia, or it is something, infectious pneumonia or something else? But if you have the Biofire, you will at least know this patient has Klebsiella. It's only that you are not growing it in the lab. And if the other circumstances warrant it, then you can give the appropriate antibiotic. I think I've talked about that. Something which is very, very important, which you have a big bearing on your outcomes, is that the sample collection and the sample submitted and the sample management needs to be done very, very well. Because if a patient gives saliva rather than giving a good going sputum from within the lungs, then you may get negative tests. And this may not be accurate. So patient gives the right specimen. If it's a swab, let it be done well. If it is a sputum, please ensure that the lab looks at it and confirms that this is actually a sputum, not saliva. I think I've talked a lot. I will invite my colleague now to look at a few of the cases we have experienced where the Biofire made a difference. Dr. Navid, come.
Thank you. Thank you, Dr. Waweru, for that part. And thanks, Adil, for the introduction. So we're going to go through a couple of cases where we found in our practice where Biofire made a significant difference. And it will iron out a couple of the dilemmas, and we'll show where, for us, where it seemed to change therapy for a patient. Case 1, 34-year-old male, weeks history of cough, fever, shortness of breath, no hemoptysis. On examination, he was tachypnic. You can see the SpO2 on room A is 83%. He's tachycardic at 112. Blood pressure is normal. This is a young male, no comorbidities, not known to have any form of immunosuppression. Comes in with what you think is some kind of respiratory infection. The trachea was central. He's got a right upper lobe dullness with increased fremitus and bronchial breath sounds. So again, you've got examination is consistent with some kind of community-acquired pneumonia here. You do a CT chest in this case, and you've got a right upper lobe consolidation. The CRP is more than 300. Procalcitonin is low. The white blood cell count is normal. Was started on empiric augmentin and azithromycin, which is fairly standard treatment for community-acquired pneumonia. You've got a lobar picture. You're expecting your bugs to be, strep pneumo or strep pyogenes. The patient is currently on 3 liters of oxygen by nasal prongs. You've done a blood gas, and the patient has respiratory alkalosis, and he's got, significant hypoxemia with a PO2 of 50. Bicarbonate is normal, and the lactate is 1.8, so it's slightly elevated. But so far, nothing to worry about. You'd expect a patient like this to improve with these antibiotics. That's the CT. And what you're seeing there is axial views of the CT scan taken just below the carina, where you can see the left main bronchus and right main bronchus. Now, what you're seeing on the left side is a pretty normal lung field. On the right-hand side, you can see the right upper lobe bronchus and all its branches. This is pretty much what an air bronchogram looks like, and this is a perfect air bronchogram because you can see all the branches of the airway. This is basically a densely consolidated right upper lobe. Again, now you start wondering what the causative organism is, and I'll put it out there. You think it could be again strep pneumo, MRSA, Legionella pneumonia, strep pyogenes, H. influenza, or mycoplasma. And any ideas here? ID specialists? So we'll move to the next one. And so 3 days later, this patient's not getting better on the augmentin and azithro. So he's clinically worse. He's now requiring 6 liters of oxygen by face mask. And, we were not able to get any sputum testing, so we elected to go straight for a bronchoscopy. We sent the BAL and we sent it for microscopy, TB testing, and we did a pneumonia biofire as well. At this point, the antibiotics were changed empirically to meropenem with levofloxacin, and this was the report. We actually got multiple organisms in this case, which perhaps would highlight one of the issues we have with Biofire. Mycoplasma, Haemophilus, and Staph aureus. Now, this particular patient, the culture did not grow anything. Perhaps the previous antibiotic use may have influenced that. And we only had this to go with the Biofire. There were no resistance genes detected, but we were not happy with the response with the augmentin and azithro, and he was improving on the new antibiotics. He went home after about a week of treatment. The question here is, was it all those bugs? Was it some of them or none of them? It becomes very hard to distinguish between which bug is pathogenic and which isn't in a Biofire panel, because it can test for everything. Sometimes it can detect dead bacterial fragments because it is a PCR-based assay. It just amplifies the DNA. But it is useful because a lot of patients, you may not get anything on culture, but you will get something on the Biofire test. The sensitivity is more than 90% and the specificity is also very, very high. The interpretation of the test is perhaps where the crux of the matter is, and that lies with the clinician. In such patients where you find they're not improving on therapy, then it becomes useful because you can tailor your antibiotics. So here, whatever he was changed to would cover pretty much all those bugs. Case 2. You have a 36-year-old female, no known comorbidities, no allergies, 3-week history of cough, low-grade fevers but no weight loss, not producing sputum. She went to the pharmacist at some point, was given Oralox, didn't get better. She went to a different pharmacist, was given azithromycin, no relief. She then went to her GP and got some Brozedex and Ventolin. The Brozedex did nothing and the Ventolin gave her some tachycardia. So by the time she came to us, she was quite unhappy. When we did her basic labs, the CRP was 7, so a little bit high. White blood cell count was normal. The rest of the tests were pretty okay. The CT scan showed left upper lobe nodular infiltrates with tree-in-bud opacities, very suggestive of TB. And this was taken from the actual report. It was reported as very suggestive for TB. There we go, that's the scan. You can clearly see around the bronchus, you can see where the bronchi tend to branch, and you've got these nodular infiltrates tending to form around the airway. This is what you call a peribronchovascular kind of distribution. And this is basically classic tree-in-bud appearance. The bronchus is basically the tree and the nodules around it are the buds. This is a very, very suggestive feature. Usually when Dr. Wera and I see this on a patient, we start to worry about TB. It is a very, very common presentation. Because there's no sputum here again, next step, what would you do? 1, you could treat this patient for TB. And if you had no diagnostics, it's a fairly reasonable approach because the CT is quite suspicious. 2, try to get a sputum sample. In this case, we couldn't. So you could try to induce some hypertonic saline, but if sometimes you don't get anything. You could send a nasal swab for a respiratory biofire. I'm not sure who would do this one, but again here it's more a lower respiratory infection as opposed to an upper respiratory. And in somebody with chronic symptoms like this, the respiratory biofire panel in this case may not be as useful. You could do a bronchoscopy and a lavage. Or you could admit this patient, change them to something like piperacillin tazobactam. This patient, keep in mind, has used 3 different antibiotics, and the best thing I think in this case would probably go for the bronchoscopy and get a lavage and send it for extended testing. Anybody who would do anything different? Good. Alright, so this patient underwent the bronchoscopy. We did it at 6 in the morning. We didn't get the results in 45 minutes. We got them by 1 p.m., which is still quite good. The first test that came out was actually the Biofire test, and we got Haemophilus influenza. We started this patient on levofloxacin. Her symptoms got better. In this particular patient, this was the rest of the report. So microscopy and culture, no organisms seen. It's not surprising. It's hard to culture some of these atypical bugs. TB gene expert, negative. Fungal stains, fungal culture, negative. And a TB culture was also negative. So this is a case that we see quite commonly, because a lot of these patients are put on anti-TBs, as Dr. Waweru said, based on a very suggestive CT, chronicity of symptoms, chronic cough, weight loss, sometimes night sweats, low-grade fevers. They probably would get better on the anti-TBs because anti-TBs are fairly good antibiotics regardless, but it seems unnecessary to treat somebody for 6 months for Haemophilus influenza. This is the third case. So this is actually a 75-year-old lady known to have dementia, multiple hospitalizations. She now comes in with acute respiratory failure, secondary to a multilobar organizing pneumonia. This patient is intubated. She's in septic shock. She's on 2 inotropes. She's got an FiO2 of 60%, PEEP of 8, so fairly high ventilator requirement. CRP is like 300. Procalcitonin is high, it's 3. White blood cell count is normal. She started on empiric meropenem and linezolid by the admitting consultant. Endotracheal tube aspirates are done, and on day 3 there's no growth. Patient is still febrile at day 3, CRP is still more than 300. This patient is clinically not getting better. Blood cultures were negative. You can see the CT scan, and this is an interesting scan because what you're seeing is widespread, patchy, mixed consolidation with ground glass opacities in all the lung lobes. Usually this kind of appearance is not specific for any pathogen. Like, you cannot look at this CT and say, for example, it looks like TB. It's not like the other one. You can't, for example, say this looks like Staph aureus or a virus or a bacteria. Organizing pneumonia of this pattern can be attributed to almost any organism. So it's very hard to identify what's causing this kind of infection, and it becomes very difficult to know what antibiotic to change to. You are already on meropenem and linezolid, so you've covered a wide range of gram-positives and a wide range of gram-negatives. You've also covered like Pseudomonas, Klebsiella, and ESBL organisms with that kind of combination. So if this patient's not getting better, multiple hospitalizations, you start wondering about resistance. And it becomes very, very important to try get some guideline or some guidance on what kind of resistance you're dealing with. The cultures here are negative. So here again, Biofire testing is probably very, very useful. But the question is, how would you get your sample and what would you do? You could add an antifungal. Seems fairly, reasonable. You're on good antibiotics and you're not getting better. That's option 1. You could do a respiratory biofire, but I'm not sure if that would be any sort of great benefit in this particular patient. In somebody who's got multiple hospitalizations, multiple admissions, your indicators are, features of septicemia. You start to wonder whether, for example, is this, do you need a panel that is going to test primarily for upper respiratory viral infections, or a panel that is going to test for lower respiratory infections and give you some kind of indication as to resistance, which is where the distinction between a respiratory biofire and a pneumonia biofire becomes very, very important. Because if you pick the wrong one, you'll have spent 35,000 and you might get something like rhinovirus or metapneumovirus, but clinically a patient like this does not fit the you know, the definition for that kind of upper respiratory infection, you need something that's going to give you a wider bacterial panel and something that will give you data on resistance. You could repeat the cultures, but now you've already spent 3 days waiting for the first cultures. Does it seem reasonable to wait another 3 days for new cultures? You could do that, but what are you going to do in the meanwhile? You have the patient who is in septic shock. She's on 2 inotropes and not getting better. You don't really have much time here. You could change the antibiotics too, but again, what would you change to? From my experience, you know, you could either use something like, you know, colistin, but it's got toxicity, or you could change to, for example, ceftazidime avibactam, but it's extremely expensive. You could add the antifungals, but you know, a single dose of caspofungin is about almost 40,000. So is it really justified? And again, do you have time to wait and see if your patient gets better? You could risk the bronchoscopy. You could lose your patient in the process. But you need to ask yourself here, what kind of sample do you need to get? And if, for example, you don't have much time on a patient, you need to collect a sample with the highest amount of yield and the highest accuracy. So if you ask us what we did, I think you can probably guess. Last option was add a steroid, organizing pneumonia. It's a reasonable option. We actually did add the steroid on this patient, but what we did was we risked the bronchoscopy. We did it at 9 a.m. and got results by 12 p.m. And this is what we got on the Biofire. We got Klebsiella pneumonia, expected, this kind of clinical picture, multiple admissions. Klebsiella is probably a very likely bug. But the question is, what was the resistance genes that came out of this? 1, it was ESBL. 2, it was carbapenemase OXA48. It was carbapenemase NMD. So you already have got indications for an extensively or a carbapenem-resistant Klebsiella pneumonia. So we changed antibiotics immediately. We put the patient on ceftazidime avibactam. This patient actually got better. Eventually we extubated the patient, the inflammatory markers came down, and she did go home. And this is perhaps one of the where we find Biofire testing tends to be very useful, and it's in the ICU population. The reason is the mortality from septic shock in ICU is as high as 60 to 70%. The highest amount of mortality comes within the first 24 to 48 hours. So you only have a small window of time to get your diagnostics done as fast as possible, put the patient on the right antibiotics, and switch as early as you can if needed. The first 3 days is probably where the patient is probably what decides whether your patient will get out of ICU or not, especially from septic shock. So we ask ourselves, yes, Biofire is good. We know it's a good test, but what are the disadvantages? And the first is probably very important. If you put in garbage into the analyzer, you're going to get out garbage. The result actually depends on the sample you send, how you collect, how you store, and how you process the sample. So if you're going to, for example, get a sputum sample and send it for pneumonia Biofire, if it's full of saliva, you're not going to get anything useful. You actually need a high quality sample to get a high quality result. The reason we did bronchoscopies on those patients is because we wanted high quality samples. The second is the potential to identify non-pathogenic organisms. If you do a Biofire, for example, on most of us, you might probably find some kind of respiratory virus from your nose. You might even get MRSA if you did a pneumonia Biofire. You might get Staph aureus, but it doesn't mean it's pathogenic. The distinction between a non-pathogenic and a pathogenic organism on a Biofire assay is very important, because if you were to try to treat everything on it, it really doesn't make any sense there. It doesn't test for all the pathogens, doesn't test for fungus, and it is fairly expensive. So, we actually have to tell the patients that, look, we're doing this test, it's like 35,000. So the best recommendation is to interpret the results in the context of the patient, the imaging, and correlate it with your culture reports where possible, so that you get a more concrete result. And if you ask yourself, so if you have this test, what's the point of the culture? So cultures can help pick up pathogens that aren't on the panel, like fungus. Susceptibility testing is more extensive on a culture-based assay. This just gives us a little indication of the resistance, but it doesn't really give us the actual sensitivity to the organisms. That takes a few days to do the isolation and to do the disk diffusions for all of it. So the Biofire guides you, yes, but if your culture tells you that, look, this is sensitive to A, B, C, then you can adjust based on your culture. So the Biofire supplements the culture assay, it doesn't supplant it. Culture is still the gold standard. We've had a couple of centuries of evidence based on this. And the question is now, what if you get a differing report from the culture and you get a different report on your Biofire? This is where clinical experience comes in handy. You need to ask yourself, do you have a polymicrobial infection, like more than one bug going on? 2, are you picking up colonizers? 3, did your Biofire or your PCR pick up like dead fragments? So again, adjust it based on the patient and the response to therapy. So don't treat the slide, don't treat the report, treat the patient. Our take-home message is fairly simple. Rapid diagnostics is where the future lies. Cutting down the time from testing to report is pretty much where the focus is. Faster results are better results. You get a wide array of pathogens on the Biofire panel, but you have to combine it with your judgment. And if you're in doubt, please trust your clinical judgment. So I'll ask here, any questions? Otherwise, thank you. Thank you for your time.
Thank you, Dr. Navid and Dr. Munyu. Very interesting and I think insightful presentations. Made you think, what do you do when you see these things? When you're presented with these results, how do you make a decision? And even when you don't have the diagnostics, you can see the kind of challenges you face. So the next presenter now is Dr. Francis Kigu. He's a consultant clinical pathologist working at the Nairobi Hospital. And he has extensive experience in clinical pathology, both in microbiology, immunology, and hematology, and especially also on the Biofire, so we welcome him. Just to let you guys know that Nairobi Hospital, I think, was the first hospital in Kenya that had Biofire. So he has a lot of experience here.
So morning, everyone. Those who are joining us physically here and those who are online. It is a privilege for me to be discussing such an important modality for testing. And I'm really hopeful that this will be an interactive session and we'll get feedback regarding this. And that at the end of this forum today, will be more enlightened in terms of the utility of syndromic testing, specifically with regards to Biofire. So I'll be discussing use of Biofire or syndromic testing with specific regard to gastrointestinal testing. And my approach will be to look at how it can improve on clinical practice. Okay? Some of it is technical aspects, some of it is interpretive aspects, some of it is clinical aspect. So I think just as a way of introduction, we have been talking about syndromic testing, PCR testing, Sometimes you'll hear it referred to as multiplex testing, and it's important to appreciate what we are referring to. So when we talk about syndromic testing or multiplex testing, we are talking about utilizing a mode of testing that is trying to simultaneously test for multiple pathogens using the same sample. And most of the times when you're talking about these, you'll find that you're talking about PCR tests, okay? So you'll have a PCR that targets multiple pathogens, and most of the time these pathogens are associated with causation of a certain syndrome, let's say respiratory syndrome or a gastrointestinal syndrome. So there are advantages to this type of testing, and I think some of it has been touched upon. One of them is definitely about the benefit of being able to test for a wide array of pathogens at the same go, okay? Because sometimes when a patient presents, you're not very certain about what the patient has, and you want to cover as many pathogens as possible. By the same stroke, it also helps you reduce on your turnaround time and time to result. And this has an impact on clinical management in the fact that you're able to get a result quite early enough, and you're able to implement the appropriate clinical management. The other aspect is, and it might seem a bit paradoxical, because one of the questions or one of the issues that is usually raised is Biofire testing is usually quite expensive. But if you were to probably test for each of the pathogens separately, one, the cost would be significantly higher, and two, the turnaround time would actually be much more prolonged, okay? And once you do your testing as well, you have an impact in terms of your healthcare cost. So we have already seen at how sometimes you stop the need for using antibiotics if it's a viral entity. And sometimes for certain patients, once you know upfront that maybe this is a viral infection, then the need for even the admission, the need for imaging is reduced. So at the end of it all, you're reducing your total healthcare costs. Then the other advantage sometimes of using this type of testing is you are able to test for organisms that are usually not readily testable by other modalities such as culture, okay? So there are some bacteria that are quite difficult to culture in the routine clinical lab. So if you don't have a modality of testing for them, then you're likely to miss them out. So there is that advantage. So, like I said, I'll be talking about the gastrointestinal panel. And one of the things that is important to appreciate is that that ecosystem, the human gut, is a very complex system, okay? As a matter of fact, the number of gut organisms that reside there total, they are much more in terms of numbers than the total cells in the human body. So if you were to go by the normal democratic process, and you have one entity, one vote, you would actually be sort of more like the refugees, and they would actually be calling the shots. So it's very important to appreciate that there are lots of organisms, and when you are testing, you're trying to pick out your pathogen against the background of very many organisms, okay? So then the concept of inter-individual variability. So for example, what you find in terms of the gut flora, what you find in children is very different. And sometimes you might find certain entities in children, and you lay more clinical, or it has a higher impact compared when you find the same to said an adult. So it's important to understand that there are usually quite a number of variations in terms of the gut flora that you get in the different populations. Okay. So this is just an illustration of what I'm trying to describe. So one, the type of organisms that you find in different parts of the gastrointestinal system are very different. So that, for example, in the stomach, you'll find bacteria such as your lactobacilli and even your Helicobacter pylori. So your Helicobacter pylori can also be a commensal and it also be a pathogen. So it's important to appreciate that. And generally, you'll find that as you progress through your gastrointestinal tract, the number or the volume or the density of your flora increases. So that by the time you're getting to your colon, you're talking about 10 raised to the power of 11 bacterium per ml. And that's quite a huge load. And the distribution of the bacteria, of course, will change so that by the time you're getting to your small intestines, you're getting to your colon, you have your, your E. coli will be there, your Bacteroides species will also be there. So again, it's important to appreciate because this has an impact to when you're trying to interpret your results. So because when we are using this panel, we are using it, I'm assuming we are using it in patients who are symptomatic, and they are symptomatic for gastroenteritis, okay? So, in terms of etiology of infectious gastroenteritis, you'll find that there are some variation, okay? And these variations are dependent on several factors. You can have variations dependent on age, like I had alluded to. So what you get as infectious agents in pediatrics may be slightly different to what you get in adults. It's also dependent on the geographical location that you are talking to. So the entities that you get probably in less developed countries compared to developed countries may be a bit different. There's also the issue of immune status of the patient. But by and large, you'll find that the morbidity and mortality that is associated with infectious gastroenteritis is much higher in the pediatric population. So various studies have tried to look at the causative agents of the infectious gastroenteritis. And some of the common organisms or the common pathogens we are talking about here include your rotavirus. We have your STEC, E. coli. We have enteropathogenic E. coli. We have Shigella, and we also have Cryptosporidium. So when we look at the Biofire gastrointestinal panel, it has quite a number of microorganisms or pathogens of interest, and they represent various classes. So for example, we have what we refer to as your diarrhegenic E. coli, and that is represented by your enteroaggregative E. coli, your enteropathogenic E. coli, your enterotoxigenic E. coli, including your O157, and then we also have your Shigella and your enteroinvasive E. coli as another group. Over and above that, we have representation of other organisms such as your Campylobacter, which is important because this sometimes is not readily available in terms of culture, or rather it has stringent requirements in terms of performing culture. You also have your Clostridium, your Salmonella, your Vibrio entities, as well as your Yersinia enterocolitica. We also have viruses of interest, your adenovirus, your rotavirus, your sapovirus, and even your norovirus. You also have representation of your protozoa organisms, and here we are talking about things like Cryptosporidium. We have Entamoeba histolytica, as well as your Giardia. So one of the question that comes up, because we said this is an important tool, but we want to make sure that we use it for the correct population. So of course one of the question is, who should be subjected probably to Biofire testing, okay? And I will be first to admit that the various regions will have different guidelines, and I think it's important for each region or each institution to come up with specific guidelines that sort of give a general overview or who should be subjected. But we do have some guidance from various entities, including your American College of Gastroenterology as well as your IDSA. And here we are talking about, one, individuals who are at high risk of spreading disease to others. We have individuals who are presenting with dysentery, individuals or patients who have diarrhea with fever, severe abdominal pains, and signs of sepsis. We also have patients who may have moderate to severe disease, patients who have symptoms that are lasting for more than 7 days, and we also have patients who are immunocompromised and are presenting with diarrhea. So this is sort of like a general guide. And again, like I had alluded to, it's up to each jurisdiction or each institution to sort of try and customize based on the needs of that particular area. So one of the things that I'm quite passionate about is when it comes to testing, sometimes when we think about testing, we sort of think about maybe what happens within the lab, okay, in terms of where things could go wrong or where there could be issues, okay? So generally we have three phases when you look at testing. We have the pre-analytic phase, okay? We have the analytical phase, and we have the post-analytic phase, okay? So when we talk about testing, it's very important to look at it holistically, because sometimes when you have issues, it happens in the other facets of testing. And what have actually been found out is that most of the issues, whenever sometimes you have errors or you have issues with testing, about 2/3 of those issues occur in the pre-analytical stage, not in the analysis of the sample. So when we talk about the pre-analytical stage, here we are talking about the pre-test probability in the patient that you are sampling. You want to make sure that you are subjecting a patient who has a high index of suspicion, so that when you find a pathogen, then it has a clinical impact in terms of the management. There is also the issue of sample collection, appropriate sample collection. When you talk about the analytical phase, you want to make sure that we have a standardized way of testing across the different setups. And then, importantly, in the post-analytical bit, we are talking about appropriate and accurate interpretation of test results. Okay. So, in terms of the sample collection and sample, we want a sample that is representative of what is occurring in the patient. And the validated sample we are talking about here is a stool specimen collected in the Carib layer transport media. And ideally that sample should be tested as soon as possible. But sometimes you do anticipate a bit of delays, so that can be refrigerated at room temperature for a period of up to 4 days. In terms of ensuring quality during the testing, because we appreciate that you're testing so many parameters, you want to make sure that the result that is being generated is factual, okay? So one of the things that tends to happen is that you will have, or rather the system has inbuilt quality controls, so that each time the test is run, those controls are run automatically. And the controls have to pass for you to be able to interpret the results. If they don't pass, then that test is regarded as invalid, and corrective actions have to be taken before repeat testing is embarked on. For the post-analytical phase, and this is where sometimes you can have a bit of challenges, and I think that has been touched upon a bit. We talked about the pretest probability, okay? Sometimes, or plenty of times, you can have patients with organisms that are just colonizers, or essentially they are commensals and they are bystanders, and they may just be tested and you pick them as being a positive result. So that is where the issue of pretest probability comes in, because you want to test patients who are symptomatic and in whom, if you get a result, it's likely to have an impact on clinical management. As an illustration of this, for example, if you consider Clostridium difficile, if you look at patients who are in long care institutions or even in very young children, very many of them will have carriage of Clostridium, okay? But just because they test positive does not mean that it warrants treatment. So for example, if you get a patient and you get probably multiple organisms turning positive, then you have to look at the clinical presentation and see which entity probably best explains that kind of presentation. So for organisms that are usually detected by Biofire, there are various modalities, or there are different ways the testing is done. So for some of them, you just have a single assay. And if that single assay turns positive, then that organism is regarded as being detected, okay? But for some organisms, you rely on having multiple assays within the Biofire panel turning positive for you to say that you actually have a positive result. So this may be slightly busy and may not be visible to people who are at the back, but I'll try and explain it. So if we take an example of Vibrio, we know that there are various species of Vibrio. We have Vibrio cholera and the others such as Parahemolyticus. So the assay has, within the assay you have a specific assay that looks for Vibrio, okay? And then you have another assay that looks specifically for Vibrio cholera. So if a patient has Vibrio cholera, then you have a report that you have detected Vibrio and you have detected Vibrio cholera, okay? But it's possible if a patient has a non-cholera Vibrio, then it will just be reported as Vibrio detected, but Vibrio cholera not detected, okay? Another example that you have, for example, for your STEC and your O157. So within the Biofire assay in general, you have two assays that are looking for your STEC, okay, your sugar-like toxin. So if they turn out positive, that is reported as such. But then you have another specific assay that looks for your serotype of O157. So for you to be able to report the O157, then the STEC must also be positive, okay? Because it's a serotype of STEC. And then another important consideration in the same vein is that if you look at your STEC, they have what is regarded to as your sugar-like toxin, and that is what usually the assay looks for. We also have your Shigella. Now the Shigella has the sugar toxin, okay? So your sugar-like toxin and your Shigella and your sugar toxin are quite similar, okay? So if you have the assay or the report turning positive for your STEC, and you also have it turning positive for your sugar toxin, then the implication is that most probably you are dealing with your Shigella dysentery, okay? So I've just highlighted that just to show that when you are doing your interpretation, and this is why there needs to be proper understanding both from the lab side and from the clinician side in terms of consuming the report, so that we don't just say this assay has too many pathogens that are turning positive. Sometimes there's a logic to it. So the other thing is, when you're looking at results, is the question of colonization versus courage. Okay, so there was a local study, for example, that was done in children aged between 6 to 24 months, and these were otherwise asymptomatic healthy children. And quite a significant number, about 20% of them, had what you'd refer to or you consider as diarrhegenic E. coli. Okay? And these are asymptomatic. Okay? So then the question for them would be, would you want to treat? Definitely not. But if it's a symptomatic patient, then you are likely to allude or attribute the positive result with causation of disease. Okay? So sometimes, as a way of confirming this report, sometimes when you have too many parameters that are turning positive, of course that becomes a bit questionable, and sometimes you'll actually want to repeat testing, sometimes even with a new sample, so that you assess for reproducibility. Because if you have, for example, 10 parameters turning positive, and I give that report to the clinician, I think it's going to generate more questions than answers. So sometimes we may ask for a repeat just to confirm some of the things that we are seeing. The other aspect to consider is sometimes you can have, it's rare, but sometimes you can have issues to do with cross-reactivity. So that, for example, if a patient has like entamoeba dispa, which is regarded to be non-pathogenic and quite morphologically and phenotypically similar to entamoeba histolytica, that may be picked up as entamoeba histolytica. Yeah? So there are quite a number of organisms. Some of them are human gut flora, and sometimes in some cases, although rare, you may have a bit of cross-reactivity. So as I wind up, I think my take-home message would be that this is a potent tool that can have quite an impact in terms of getting results readily and having an impact in terms of treatment and management. And it can also assist in terms of antimicrobial stewardship, because we appreciate that antibiotic resistance is a serious challenge. And also it can also be of much benefit in terms of managing healthcare costs. Thank you very much for your attention.
Thank you. Thank you, Dr. Kigu, for a very informative and educative session. I think most of you will agree there's a lot of information that was there, and you have definitely learned something, even for those who said they were experts in syndromic testing. So this brings us to the end of the session. I think now we will be having a discussion for the three presenters. So the floor is open to the participants who are here. If you have any questions specifically to either Dr. Waweru, Dr. Navid, Dr. Kigu, or even from those who are online, online participants. If they have any questions, we request that you post them on the chat box, and we can take them from there. So, to the people around here, in the group present here, any questions? So this, I think, is a question for Dr. Waweru. The example of a patient with metapneumovirus on Biofire is a good one. In view of the rapidly evolving nature of SARS-CoV-2, the current circulating variant is an Omicron variant, for example. My question is there ongoing revalidation of the assay to avoid false negatives due to target gene failure? Maybe Dr. Waweru and maybe someone from Biofire, because this seems like a very technical question.
I will allow Dr. Sigei to answer that because he's in the thick of things.
Yeah, I think for that question, the short answer is we always update based on emerging trends in epidemiology. If you remember, even when COVID, even before the current variants, several other variants have happened since 2020. So normally we give an communication once we have revalidated it. And so far we've not had an issue with detection despite the variant. So the short answer is yes, we always make sure we capture whatever is changing in the environment. Thank you.
Any other questions? Anyone here? Maybe I'll ask a question to Dr. Kigu. I know that the GI panel, whenever it's done, you often get multiple pathogens identified. It's not unusual. So how do you, as a pathologist sitting in the lab, because the clinician then will come back to you and ask you, how should I interpret these results? And so what usually is the feedback you give them, and how do you deal with those questions?
Yeah, I think that's, it's always something that we encounter quite frequently. So sometimes it helps quite a lot when the request comes with detailed clinical history. But for such cases, what we normally do is we'll get in touch. It's on a case-to-case basis. So we'll get in touch with the clinician. We'll ask them, how is the clinical history? Has there been any antibiotic therapy? And then we sort of are able to narrow down probably to one or two pathogens and see what is likely to be the clinical management. I think a good case, or most of the times, most of the organisms that we get being positive are your diarrhegenic E. coli, okay? So you'll find maybe a patient has diarrhegenic E. coli, and over and above that, they have something else. So from our approach, what we normally do is we get in contact with the clinician, we discuss the case, and we sort of try and narrow down in terms of what is likely to be the entity that is likely to be pathogenic. So it's just a question of having a discussion and then trying to see whether there is a solution to that.
Okay, yep, thank you. Let's go to full screen. So maybe this question can go to Dr. Kigu first, and then someone from Biofire. So the question is, for syndromic testing, do you use any sample like blood and CSF, or is it limited to GI specimens only?
Maybe I can respond to that first, and then someone from Biomerio can respond as well. So for syndromic testing, we have different panels looking at different syndromes. And for each of the panels, the sample that is validated, for example, varies. So if you are talking about the gastrointestinal panel, for example, the validated sample is stool. If we talk about your respiratory panel, then the validated sample is your nasopharyngeal swab. Again, if you're talking about the pneumonia panel, then you're talking about validated samples being samples from the lower respiratory tree. You're talking about your sputa, you're talking about your bronchoalveolar lavage. So it varies depending on the panel.
Okay, thank you. Dr. Sige?
Yeah, just to add, we have 6 panels currently validated, and each has a specific sample, just as Dr. Kigu has mentioned. We will be explaining a little bit more during the bioMiri presentation, and those in the room have some reading material that can explain all that. So for the moment, 6 panels, 6 different samples, and we'll share more details. Thank you.
Okay, thank you. So the next question is from Dr. Cyrus Madeka. This, I guess, will also be to Dr. Kigu. So for hospitals outside Nairobi, and then maybe bioMiri can also take this. For hospitals outside Nairobi and would like to refer samples for Biofire testing, what are the pre-analytical considerations as samples are transported?
Yeah, it's a good question. So, so the question here is sample stability. And the recommendation, of course, is for the best diagnostic performance, you want to do your testing as soon as the sample is collected, but you can get up to 48 hours. If the sample is refrigerated at 2 to 8 degrees, the viability is still there for up to 48 hours for you to do the shipping for subsequent testing. So there is that leeway.
Okay. Anything from bioMiri to add on that?
I think maybe Edwin can comment on this.
Oh, Edwin Masese, yes, please.
Yeah, so thanks. So maybe just to respond to that, each sample or each panel rather has its own specific sample type. And maybe I can say, like for respiratory, you can use any viral transport media. Could it be AMIS and the rest? For CSF, as Dr. Kigo said, yes, we recommend maybe between room temperature, maybe up to 2 days or so. And also, if refrigerated, I think up to 3 days, that can work. For stool, yes, you can use a transport media if you are collecting from outside maybe the center ways. If you're using the hub and spoke model, you can use the Carib-Blair transport media, but the liquid, not the gel. Yeah.
Okay, I think that's good to know. The next question, so I guess this is for Dr. Waweru and Dr. Navid. So the question is, in cases where a patient has a multi-resistant organism like Klebsiella oxytoca, Pseudomonas aeruginosa, Cinetobacter baumannii, resistant to all drugs, what do you use for treatment? So I'm guessing you have met these kind of patients, so you can give from your experience as well.
Yeah, those are very dicey patients, and that is why we should do our best not to get there. There are certain antibiotics which have not been used much, things like colistin, polymyxin B. Those can be checked, and you see whether they can work for that group of patients. And then also ceftazidime avibactam is a newish kid on the block, which we have tried for some of these patients, but it can be very difficult.
Yeah.
You want to say?
Maybe Dr. Navid, your experience?
Dr. Waweru captured it. It's not an easy thing to treat an extensively resistant bug. If you're resistant to, for example, even colistin, then I think you're going to be in some serious trouble. The best approach would probably be to use something that hasn't been used, like ceftazidime avibactam. The current discs, I don't know if they actually can test, if they do test for resistance to ceftazidime avibactam yet. And I don't know if there's too much data yet on resistance to ceftazidime avibactam, because it's a very new drug. That's probably going to be your best. If it's a bug that, for example, it doesn't have activity on, for example, like Acinetobacter, then it becomes extremely difficult. Then a combination approach is probably the best. I would talk to ID here in this case. You'd probably end up using combination of like a carbapenem with amikacin, with something else, and see what works, because there is also a slight difference, for example, between in vitro sensitivity and what may actually work on the patient. But that's a very, very difficult place to be in, and that carries a very high mortality for the patient.
Okay, maybe Dr. Kigu would like to tackle the question of testing.
Yeah, maybe I can chime in. So we do have modalities for testing for something like ceftazidime viductum. We have e-tests, which is gradient diffusion testing. And worryingly, we are seeing quite a number of isolates, especially Pseudomonas aeruginosa, that are pan-resistant, ceftazidime viductum resistant to colistin. So essentially, you don't have any option, and for those patients, it's more like try and error because you're just trying to do combinations and see whether there is any response. So there are modalities to test for even ceftazidime viductum in case of resistance, yes.
Okay, thank you. That's good to know. So the next question, I guess, is for all three participants. So one from the clinical, you can respond from the clinical side, and then Dr. Kigu from the lab side. So the question is about the respiratory panel. The nasopharyngeal swab, do you prefer sample taken at a specific time of day, or do you advise the patients to take a random sample? So maybe you can start from there and then back to you. You can just give them the mic, please.
For those patients who have those kind of problems, I don't think there is any specific timing. Similar to what was found with TB, in the going by days, we used to say you do an early morning sputum. We have moved a bit in the sense that you take the sample when you have the patient, and then I think Dr. Kigu can add more if there's any new thing.
Yeah, there are no restrictions in terms of timing. I think the only thing to make sure is that the sample is collected adequately in terms of making sure that there is sufficient material, that the area is swabbed properly so that you have a representation of what is there in the nasopharynx. So timing is really not a concern.
Okay. Thank you. So I think online, those are all the questions we had. Is there any other question from the group here? Okay, it doesn't look like. So I think we'll give a big round of applause to all three participants. Thank you all. And I'll hand the mic back to Dr. Sikei.
Thank you so much, Dr. Adil. Thank you, everyone. So again, apologies, we're running behind schedule. I'll request that we take a 15 minutes break, very quick, so that we come back. At least people can stretch a bit, grab a cup of coffee. Let's be back within 10 to 15 minutes. Those online, you can also take a break. Thank you for staying patient with us.
Check.
Thank you very much. Good afternoon and welcome for this session. It promises to be a very interesting session which will take us to the practicals. What is our data showing us about this biofire? How do we internalize whatever is happening so that you can use this test appropriately? Our next presentation would have been done by Dr. Charles Kuoba, and I ask that we take just a few seconds to put him in mind because he lost his wife and that's why he could not travel. Just a minute for that. On his behalf, Dr. Sigei will do the presentation, and you're very welcome, Dr.
Thank you very much, Dr. Aweru. And again, on behalf of Biomiriu, we'd like to send our condolences to Dr. Kuoba and his family on this untimely loss of his wife. They were able to share the slides of the work they have done at MTRH, and I'll briefly go over them because it's an important study, one of the local studies on biofire, and we felt it would be good to at least share some highlights with this audience. So the study was titled Etiology, Risk Factors and Outcome of Meningoencephalitis among adult patients at MTRH, which is a Moi Teaching and Referral Hospital in Eldoret. And it's a study that they started about 2 years ago and just completed some of the milestones, so they were able to share this data, which I'll go over briefly. So we start with a very brief background, just to give an overview of both meningitis and encephalitis. In less than 50% of cases, we have the classical symptoms of headache, fever, and neck stiffness. And again, in 95%, you may have other symptoms as well. So, and with encephalitis, the main difference is personality shifts, changes in the neurological system, mental status, as well as focal neurological deficits. So what the point is to show that clinically it's not always easy to pick it. They are classical symptoms, but they don't always present very much like that. The main causes remain bacterial, fungal, and viral. And there are some risk factors that can predispose patients to getting meningitis or encephalitis. And the mortality rate is quite low in the developed world, but if you look at our setting, it can be up to 90%, and I think we all are familiar with the challenges around diagnosis and treatment of these conditions. The incidence can be quite high. There is a famous section of sub-Saharan Africa called the meningitis belt, stretching all the way from West Africa all the way to East Africa. And Kenya's northern part is part of it. And there you do have epidemics that sometimes occur, particularly meningococcal epidemics. So let's talk about diagnosis. And traditionally what we do is, we have to get a CSF sample, first of all. And we do several steps, which include the microscopy, culture, and sensitivity. We also do biochemistry. We do CRAG, which is a cryptococcal antigen, very important, especially in our high burden HIV setting, cytology, and cell count. And it's very hard with those basic diagnostics to actually get the etiological agent in many cases. And in about 62% from this study that was done locally, they were not able to actually isolate the causative agent. So the background again to this study is that there were two tools that they were looking at. They were looking at the GeneXpert tool for TB diagnosis, tuberculous meningitis, but they're also looking at the multiplex PCR from Biomiriu, which is the Biofire. And basically they were trying to find tools that could then help them pick more causative agents, give them better results in terms of diagnosis. And we've all heard about the Biofire. It was explained, quite rapid, 1 hour, quite sensitive and specific. And the yield sometimes actually surpasses that for culture. So based on that background, there is a problem statement. We have a high incidence of meningitis and encephalitis in our population. It's very elusive to identify the etiological agent. There's a high mortality associated with it, and there's limited data on outcomes from those who are investigating this. So they justify that by saying, we want to define the etiology in this particular population. We want to improve diagnosis as well as antimicrobial stewardship, and then also get information around outcomes which can help benchmark future interpretation of the epidemiology of meningoencephalitis. So they have one broad objective, which was to determine the etiology, risk factors, and outcomes of meningoencephalitis among adult patients at MTRH, and those are then broken down into specific objectives, one looking at etiology, one looking at risk factors, and one looking at day 14 outcomes. So in terms of methodology, again, just to reiterate, it was at the MTRH. The focus was on adult patients admitted to the medical wards of that facility who met the inclusion criteria. It was prospective in nature with consecutive sampling. In terms of eligibility criteria, 18 years and above is the definition for adults with suspected meningitis or encephalitis. They excluded those who had skin infection over the needle entry site, patients with papilloedema, which indicates increased intracranial pressure, and CT scans which might have shown a space-occupying lesion or any mass effect. So this is a flowchart of how the patients were included into the study, pretty much summarizing what I've just highlighted previously. Of course, consenting was done, basically, and then followed by a questionnaire which captured some of the clinical data, as well as now the CSF sample, which was subjected first to routine diagnostics, but also to both the Biofire and the gene expert. And then, of course, there were blood samples done for other tests, and after that, standard of care was administered and patients observed. So in terms of results, in terms of the basic socio-demographics, it was pretty evenly split, male-female, with an median age of around 42. In terms of HIV status, over 80% were HIV positive. Those on antibiotics was 50-50. And those on anti-TBs, very few were on anti-TBs, just about 7. Clinical characteristics, most of them had meningitis as per their clinical presentation. There is a subgroup that did have both meningitis and encephalitis, and according to the clinical presentation, none was found to have encephalitis. So in terms of your clinical presentation, majority of them coming in with the classical symptoms of headache, neck stiffness, and fever, but we also had other symptoms as earlier alluded to. So if we go objective by objective, the first one, they wanted to pick out the etiological agents. So over 40% were found to have Cryptococcus pneumomans, cryptococcal meningitis basically. Another 16% came in with TBM. And then we did have viral meningitis, CMV, varicella zoster, as well as HHV6, and then a few others with bacterial confirmation. 22 were not able to be identified on all the modalities used, and then there are those who, despite the clinical presentation, actually was classified as normal. So just going deeper into this, and this might be a little bit unclear for everyone, but I want us to focus on a few things. If you look at the first row at the top, it's looking at CSF culture, and 74 or 78% were found to be culture negative. If you look at the multiplex PCR, 69 were PCR negative. So PCR was able to pick an additional 5 from those that were culture negative. And additionally, PCR was able to pick viral causes, CMV, varicella zoster, as well as those who had multiple presentations. So We have, for example, a patient who had CMV and HSV6 co-infection. Those with CRAG positive were 37, which was just 39%. And then again, those with the gene expert detected, only 15, whereas 79 of them was not detected. So in terms of, again, sticking to the first objective, those who had antibiotic exposure but CSF culture negative, they were not able to isolate any additional bacteria from the multiplex PCR, suggesting that the antibiotic exposure had really reduced the amount of bacteria there. Those without antibiotic exposure and culture negative, there was one that was able to be picked by the PCR. So again, you can see the value of this solution, particularly where you have CSF culture negative. And then there are those who antibiotic exposure, who did not have antibiotic exposure and were negative on the PCR. They were able to pick 2 on culture. So again, just as alluded to by previous speakers, sometimes you do need to still depend on the culture, particularly if the pathogens are hard to pick on the PCR. For Cryptococcus neoformans, again, 38% of them of cryptococcal yield was culture negative with CRAG alone. So CRAG is still a very sensitive test, particularly for cryptococcal meningitis. And then again, they're able to grow it from 2 samples, which were both multiplex and PCR negative and CRAG negative. So culture is important on that case. And there was one case where both culture and CSF CRAG were negative, but the PCR was able to pick that. So the PCR sensitivity here is a bit lower for crypto, and that's something we also mention normally. And some of the algorithms actually do have the CRAG come in before the PCR. Again, for viral, just want to emphasize, if you think about viral causes of not just meningoencephalitis, but a lot of conditions, including pneumonia and gastroenteritis, we really don't have good tests for that. The tests are either very difficult or not routinely done for viral culture. So again, this is where this solution really comes in to support additional diagnosis of viral causes of meningoencephalitis. If you look at the risk factors, again, HIV positive, as I had mentioned earlier, over 80%. So obviously this particular population, which was a total of 94 patients, very heavily skewed to immunosuppression, then that would mean the causes of meningitis obviously are different from the typical ones if in immune competent patients. But we also have other risk factors, chronic alcohol use, chronic lung disease, diabetes, were also identified as risk factors in this particular population. So in terms of co-infection, just to show that we do have quite a number of that happening in this population, especially in the context of HIV infection. Looking at 14-day outcomes, again, in terms of the third objective of the study, 55% after 14 days remained alive and admitted, 28% alive and discharged, and unfortunately 15 had passed on. So a lower mortality than would be expected compared to the other data that we've seen, but something just to note. So in terms of discussion, so starting with the etiology, in HIV high burden areas, this data is quite similar to other studies done in other countries as well as within Kenya. And of course with low HIV burden areas, then it would mirror what especially occurs in areas where we don't have as much HIV infection. Then there's a complementary nature of diagnostic modalities, which is very important, and I think that's something we want to emphasize, because when you look at, we don't want to say we are replacing standard of care, but in certain cases you do need the PCR to complement the culture and vice versa. In terms of risk factors, I think we can just appreciate it's similar to other studies. HIV infection being quite significant in this population, but these other risk factors have also been seen in other studies. So I want to go to study strengths and limitations. First of all, here they were able to include extensive catalog of tests. I think routinely you would not have patients getting all these tests in our typical hospitals, including not just the public, but even in private. So one of the strengths of this study is they were able to ensure the patients got the best that was available. And then the most recent advances on the PCR platforms, the GeneXpert and the multiplex PCR. The limitations, the VDRL and TPHA assays on CSF were not included, although they did have serum VDRL. CSF cytology was not included, and possible predictors of mortality and quality of care were not part of the study. And the risk factors documented based on the prior history, pre-existing pathology and other chronic factors. So in terms of conclusion, the most common cause was picked as Cryptococcus neoformans, HIV being the most common risk factor associated with meningoencephalitis in this population, and majority of them remained hospitalized at day 14 of follow-up. They did also note that there was a lower mortality reported, approximating those of the high-income settings. So they did make some recommendations. There should be some prophylactic measures for cryptococcal meningitis, especially in persons living with HIV. HIV testing should be done for all presenting with meningoencephalitis, and early diagnostic and treatment strategies to be implemented to assist in reducing mortality. So I think with that we have some acknowledgements and references, and with that, thank you very much.
Thank you very much, Dr. Sigei. I don't know if you'll be taking some of those burning questions from the people here later on. Our next presenter is Dr. Mutai. She has flown all the way from UK, United Kisumu. She's a PhD in medical microbiology based at the Basic Science Laboratory, Cambridge, Kisumu. Karibu sana, Doc.
Thank you, Dr. Wawelu, for the wholesome introduction. Yes, I came from Kisumu. That's why I'm freezing. So thank you so much for your time, for the invite to come to share your space. I come from the other side of the space where we look at things to answer questions, and really do interact with the patient. But every time we do interact with the patient, so that probably when you get a product from Biofire, it's a product that has been looked at and it's good to go. So I come from a research lab, that is the KEMLI, the Waterlid-Ham Institute of Research. We are based in Kisumu. Our lab is called the Basic Science Lab. And the department that I work with, it's emerging infectious disease surveillance program. And specifically, we look at acute febrile illness. Thank you. So the acute febrile illness surveillance program, and we do it together with the respiratory surveillance, that is a partnership. It's not just an effort with one lab. We partner with the Kenya Ministry of Health, Kenyan Defense Forces, and our partners, Colonel Rebecca and your team. Thank you so much for the partnership. And then also we partner with a lot of US agencies to determine what pathogens that cause febrile illness and respiratory illness, determine and monitor disease outbreaks in our population and in our species, and then understand how pathogens are important to our country from wherever, and also their geographical distribution in the country. And like I said, the lab that does this is in Kisumu, the Basic Science Lab, and we work with a network of hospitals, county and sub-county hospitals, and of course our Kenyan Defense Forces partners. So what's the objective of this activity? Is to determine the infrequently reported pathogens that cause clinical febrile illness and or respiratory illness in Kenya. And in so doing, we'll be able to monitor emerging infections, outbreaks, and pandemics. Why do we do this? In the last 2 decades, we've seen there's a lot of emergence of new pathogens that we never thought of, or that were eradicated, but they are coming up. And they keep causing febrile illness or other illnesses. So it's good to know what is happening, and in that way, that's the only time we can tell what diagnostic measures should we be thinking of. What will people like Biofire look at and include in their panels? And then for the outbreak, we'll try to understand. Sometimes when an outbreak occurs, it's not easy to determine what's causing the outbreak. But then with the technologies like Biofire and other technologies in the research labs, we are able to identify specifically what pathogens are these causing the outbreaks, and then we are able to have the right diagnostics, the right treatments, and also contain the epidemics, and of course like the SARS-CoV epidemic that we took. So what have we been looking at and what have we been seeing? This is how we've been seeing things in Kenya from 2022 to 2023. That's what I just want to show. All the samples that we receive in our lab, around 63% of them, we find an etiology. We look for things that are endemic in Kenya, for things that there's a risk because of there's a vector presence in Kenya, or there has been a case reported in Kenya. So we look for all those pathogens, almost 50 pathogen plus, and we keep improving and expanding this panel. However, around 37 of them, the black box, we don't find anything, meaning there are other causes of febrile illness, like our colleagues, the earlier presenters have said. We have the pneumonias and all those things that we are not looking at. They could be cancers or those allergies that could be causing febrile illness. So, however, what this says is that there is need to keep improving our diagnostic measures, expand what we know, and also keep improving on what is already available. And that's the whole reason we do this kind of work. So how do we do this? Like I said, we are situated and have presence in different parts of the countries, either in county, sub-county hospitals. And in those places, we have a clinician, a clinical officer, a nurse, a lab tech, and sometimes medical officers who recruit the patients, consent them, take the samples, and then ship those samples all the way to Kisumu using a courier system. We've established how those samples are kept very cold and they get to us very viable. So all the way from Londwa, Ramu, from wherever the country, we are able to receive those samples overnight using a courier system. So when the samples come to the lab, we take those samples and we do different kind of testing. One of the testing methods that we use is the Biofire, and we'll see. And then we use a lot of PCR, targeting, looking for different pathogens. When we find something, we want to confirm that this is really the virus, this is really the bacteria, this is the parasites. So we have the sequencing capability, we do whole genome sequencing of all these things just to confirm. And that answers the question of the participant who was asking, how do you confirm that DNA that you're finding belongs to this? There's a lot that goes to that. So having all this infrastructure, all this network, we were part of the group that did the global fever panel clinical evaluation globally. So one of the sites that did that was our lab in Kisumu, and the Biofire team, the Biomure team can now say the global fever panel has received the FDA approval. So we should look out for it and include it and expand the panels that we are doing. So the next question that I want us to ask ourselves is why the global fever panel. We've been told a lot about the respiratory that has made really patient care much better, the meningitis and all those panels. But now we want to look at why the global fever panel. So like we said, a lot of things can cause febrile illness in our hospitals and globally. And the etiologies that cause that, the number is endless. A lot of them endemic in Kenya, in Africa, and globally. A lot of them are emerging in places that they were never reported before. And the others, they are very infectious. And like you can see, the viral panel, that includes all the viruses that in the last 2 decades, they have been emerging in new places. They have caused a lot of outbreaks and they are very infectious. So for example, if a patient comes to the hospital, is suspected to have Ebola infection, maybe the person had traveled to West Africa or wherever, it causes a lot of panic in the hospital. The first thing you need to think about, how can we contain this to avoid our people, our healthcare providers getting infected? How can we control from where this patient coming with contact tracing and making sure it doesn't spread? There's a lot of panic that comes with. If you are to do this by trying to isolate the virus from this patient, it will take weeks. If you try to do this by doing each individual PCR analysis, it will take weeks. However, the Biofire panel, within an hour, you are able to eliminate, was it Ebola, is it Ebola, is it Marburg, is it all those? And then you'll induce the panic, you contain it very fast, and you treat your patient with targeting a specific pathogen. The bacteria, there's a lot that can cause febrile illness. Some of them are very infectious. Some of them we don't test routinely, but they are there. They are being reported elsewhere. And like we know, diseases nowadays travel faster, or pathogens travel faster than us. COVID in China today, tomorrow it's in Kenya. The same time our flight takes from there to here. That's how fast it will travel. So it's good to have this capability to rule out what could be causing this. Then if you look at the protozoas, the last panel, we have malaria, we have leishmania. Those two infections will almost look the same, but treatment is totally different. So if we don't have proper diagnostics that differentiate the two, we might be treating a patient thinking it's malaria, that we are not seeing the parasites, but it's actually leishmania, and we know there's a lot of that in Kenya, or the other way. Then if you look at the malaria infections, there are different kind of malaria infections. You could be dealing with malaria that is not commonly found in Kenya. That's the species that causes the severe malaria in Kenya. It's something else. So we might be using even medication, just like the antibiotics. We might be using the ATCs to treat Plasmodium ovarian infection, which we really don't need, and then brings about the problem of antibiotic resistance. So it's this kind of testing will always help us deal with the specific pathogen, not misuse antibiotics, antimalarials, and also know when it's a very infectious pathogen and when it's not. So the next thing, if we were to do the normal PCR for this kind of test, of course we'll use molecular trained personnel like myself or others. However, with the Biofire, anyone, I believe even the doctors who are not lab people can easily perform this test. It's very easy. You take the sample, you put in the pouch, and then you put in the machine. Not a lot of pipetting, not a lot of mixing, and all that. And in a very short time, you have your results. And the next one, the results are very easy to interpret. Like, for example, what I'm showing there are two different kind of specimens from patients. One of them, it gives you a panel of all the things that were tested. Then it tells you this patient has dengue virus and has a malaria infection. So you can imagine if this patient came traditionally to our hospital, we look for malaria parasites. Definitely we'll find it, right? And that's because that's the known common of febrile illness in Kenya. We'll treat for malaria. The patient will still remain sick. Why? They have a dengue infection, which requires totally different kind of treatment compared to the malaria infection. So you see this kind of test is going to tell you this person has dengue virus infection, which can be fatal if not treated well. And they too need malaria treatment. And then it tells you the patient don't have all those other things. The next thing, it looks for all those things. You know the patient has a malaria infection, and not only do they have the common malaria infection, we know in Kenya that Plasmodium falciparum, they have Plasmodium ovari. So that helps you make your judgment on how you treat the patient very specific to what kind of malaria infection. So what the take-home message here is that this is going to be fast differential diagnosis of febrile illness, and it's going to add value to how we take care of our patient. So the next thing, and this is what I was trying to say, when in situation where there are Marburg outbreak in Tanzania, Uganda, West Africa, we are very alert at the borders. If someone came in sick, probably they'll be rushed to Aga Khan Hospital, Nairobi Hospital, or Kenyatta National Hospital. Then they cause a lot of panic. But if this kind of test was there, it's going to be fast and also minimize the risk of our healthcare workers, because it doesn't need a lot of vortexing, centrifuging, pipetting, all that. So this too is going to be a very good tool. It minimizes the risk of infecting our healthcare workers, at the same time giving us a very quick answer. So I think I wanted to convince you to look out for the global fever panel, to hand to the list of panels that you are using from the Biofire. And thank you so much. Mine was very short, but of course I can't end without acknowledging our partners, the county hospitals, Kenyan Defense Forces, and of course the people who fund us to keep doing this work, because Biofire is expensive. Thank you so much.
Thank you very much, Dr. Mutai. Very nicely done, and we are very proud to have Kenyans participating in developing some of this cutting-edge technology so that we also contribute to the future of this world. Next, we will have Dr. Magali D. Koning. Magali is a biotechnologist, obtained a PhD in molecular biology from Autonomous University in Madrid. She has 8 years of experience in molecular biology, ranging from oncology to infectious disease diagnostics and public health. In her current role as scientific officer for Presence Care, Magali is contributing to making quality healthcare accessible to all through operationalization and deployment of fit-for-purpose mobile laboratories at the last mile. Daktari, that's how we call doctor here. We welcome you to give us your presentation. Thank you.
Hello everyone, thank you. Thank you for the kind introduction, and thank you to Biofire for the opportunity to share our experience. I hope you can see my screen and hear me well. As unfortunately I was unable to make it there in person.
Yes, you can. Go on.
Yeah, so I'm here today to share about our recent experience of using the Biofire in a field setting in Kenya, in the particular context of a mobile lab, as you can see here. At Presence Care, we are a company that is based in Belgium, but we have activities in different regions worldwide. As an overarching mission, we want to contribute to making healthcare more accessible, and we do so by tailoring our services to the first step of the care cascade, which is diagnostics, so to bring it closer to the point of need. And for this purpose, we have conceived, designed, and built a fleet of mobile labs, as the one you can see in the picture. So our approach is really to create vehicles, to create platforms that can span different activities, navigate different scenarios, and be deployed from all the way from routine tests to surveillance and to outbreak response situations, without compromising on the quality and the safety of the lab for the operators. We started as a foundation, really. So after the Ebola epidemic in West Africa, but yeah, since then we have shifted to a for-profit model, but always keeping impact front and center of all our operations. And we've had some trajectory in the African continent, starting in Senegal since 2017, where we have been deployed and have been supporting numerous dengue outbreaks and also the COVID-19 response. We've detected around 10% of all national COVID-19 positive cases with one of our mobile labs, so that was quite an achievement. And we are part of the national 4S surveillance network for respiratory viruses and tropical fevers. As part of our scale-up operations, we also signed an MOU, a Memorandum of Understanding with the Africa CDC in 2018, with different pillars related to emergency preparedness response, surveillance, laboratory networks, and so on. And we've also airlifted one of our mobile labs to DRC, to Goma, to reinforce their Ebola response capacity. So over the course of the years and with our experience, we've improved our mobile labs. Now they are called Bioneers. The idea is to have polyvalent open platforms to adapt to different scenarios, to different uses. But at the core of this platform is a biosafety isolator, a BSL-3 isolator that allows us to manipulate highly pathogenic samples or highly suspicious samples. It's a fully autonomous multi-terrain vehicle, and we've also gone through the process of accrediting one of them for ISO 15189 for medical labs. So it's a fully accreditable platform. And now the project that I wanted to talk to you about today has taken place in Kenya recently. So last year we shipped one of our Bioneers to Kenya to coordinate an impact-driven intervention study that was funded by FIND and with collaboration from our partners at JQuat and the County of Mombasa. The idea was to reinforce the existing diagnostic capacity and address some of the existing challenges, such as inaccessibility, lack of high precision testing, capacities at different points of the laboratory network, and addressing also the suboptimal diagnostic referral networks. And one of the numbers that we came across during our baseline capacity assessment was that, for example, the county referral hospital, the Coast General Teaching and Referral Hospital, receives an average of 200,000 medical diagnostic requests each month, but can only process under 25% of them. So the idea to introduce a mobile lab that could work in more proximity to patients while still collaborating with the existing networks and building referrals was tested during this pilot study. So in general, we aim to support diagnostic capacity, but we had some more specific goals as well to map the diagnostic, to map the disease landscape and map the diagnostic capacity across different levels of the healthcare system. Also to find a financially viable model that could work in the long term. Then train a local team for the use of the Bioneer. All of our Bioneers anywhere in the world, they're always locally operated and coordinated by local staff. And then we wish to determine the impact and challenges of introducing the Bioneer in such context. So very briefly, we had a pilot study of 16 weeks. We supported 13 health facilities, and we designed a routing, so we'd spend normally 1 week at each healthcare facility, returning also to several of them. And in addition to this more routine scheduling, we also participated in some county organized medical outreach campaigns. Just to share a bit the scope of our capacity, we offer a wide scope of equipment ranging from more routine equipment, so for hematology, for clinical chemistry, to more advanced tests, PCR-based or molecular diagnostic tests. And part of our services is the Biofire, the Filmary platform, as we think it is highly important to include such a wide scope test, such syndromic testing for surveillance and outbreak response, especially as part of our capacities. So we designed an assay menu, so that is based on local disease landscape and on local disease priorities. Of course, always starting from feedback from the local clinicians and guided by the national EDL, the essential diagnostics lists, to guide us. But we've had during this project different clinicians from Mombasa County, and we had a pathologist from JKUAT also on board that have been guiding our clinical decisions and the scope of the tests that we've been offering during the pilot study. So for the presentation today, I wanted to share actually two important uses of the Filmary that we encountered during our pilot study. They have been both during small outbreaks in Mombasa County. The first one was during a gastrointestinal outbreak among infants that was in early 2023. There were more than 100 reported cases with unknown causative agent, and the cultures of the samples that were taken from these children, they all tested negative. Normally in this situation, the samples would have been referred to KEMRI in Nairobi, but instead this time they were referred to the Bioneer that came to near Coast General Hospital, and samples were tested on the spot, on site, and result was given 2 hours later. And the test on the gastrointestinal panel of the Biofire revealed co-infection of 3 pathogens, so rotavirus, Campylobacter, and Cryptosporidium. So that's also something unusual to be able to detect co-infections, which is one of the interesting values of this type of panels. But identification of especially rotavirus, which was the driver of this outbreak, contributed to rapid management, to rapid decision-making at the level of the county, and to identify more, in a targeted way, additional infections, additional cases. We also had a second use case during a cholera outbreak that was also around the same period in Mombasa County. There were over 50 suspected cases, and one of them was diagnosed on the filmary in the Pioneer. So again, on board of the mobile lab on site, with no need to ship the samples anywhere. Testing was done on site, and again, this enabled the Department of Health of Mombasa County to take rapid mitigation measures. So from our experience on the field, there was really high value in being able to offer such a wide syndromic test. Well, first of all, we got the feedback that there was high value in training local laboratory staff from the public health system. Most of the lab technicians that were part of the Pioneer team had never been trained or had never been in contact with a filmary system. But also, we really found out, different type of challenges, administrative challenges, supply chain challenges. We also started with a limited scope of testing, but received demand for other type of tests. But the idea is to build further on this menu that we started with. And a few challenges to mention here today are the lack of reimbursement options so far have avoided patients from seeking services from the Pioneer. So that's one of the issues that we are working in moving forward with local partners to see how we can embed this in the healthcare system. And also it seems that there's still today quite low sensitization to the value of multiplex approach at all levels. So really the clinical value of such tests is sometimes questioned by local operators. But overall, the project was quite successful. It was the first level 3 mobile diagnostic lab that was deployed in Mombasa County. And during the course of the pilot study, it has been recognized as an official health facility in Kenya. It has been registered as such. We had good impact in the delivery of diagnostic services in terms of turnaround time and convenience for patients, so travel time, etc. We built capacity also, so we trained a team on a very wide scope of tests, and with the idea that this platform can be continued to be operated locally. And importantly, we've supported the county during a few outbreaks during this time. So overall, it has been a good experience. So just before I finish, I wish to thank our partners, so FIND for funding the study, the Ministry of Health and the County of Mombasa for all the support and implementation, and the JQuat DHARC team, who have been crucial for implementing this project. I hope this was of interest to you. Thank you all for the attention, and I'll welcome any questions during the next Q&A session. Thank you.
That is very interesting, Dr. Magali. Very, very interesting and impactful initiatives, which I think would do a lot of good to this country if upscaled. Of course, we recognize the challenges that you are talking about. Thank you very much for that information. I'm informed now. I didn't know about that program. Thank you very much. We will take the next 10 minutes or so to take a few questions as we wait for our next speaker. I welcome questions from the people here and the people online. Dr. Sige, if I may start off, when you did your presentation, I got a bit confused. On one of the slides, you had mentioned a sensitivity of 100% for meningitis and then less than 50%. Would you comment about that? I think it was about one of the slides. As you look for those slides, for Dr. Beth, I'm assuming there is no one with a question. Any questions? Yeah, please.
Good afternoon. My name is Idris Malaba from Checkups Medical Hub. So my question is to Dr. Magali. Now that the Bioneer mobile lab is currently in Mombasa, is it kind of stationary there, or we'll find it moving? Maybe next time it will be in Eldoret or Nairobi. Then what are some of the challenges that they encountered during the registration with the lab board, KMLTTB? Thank you.
Thank you for the question and the interest. Right now, the Pioneer is still located in Mombasa County. We are currently building the next stages of this implementation. Right now, the pilot study has concluded, but of course, we wish to implement it in a more sustainable and long-term way. Of course, we are right now exploring the possibility of setting up a PPP, so a public-private partnership involving numerous players, so from public-private sectors, to jointly deploy the Pioneer in Mombasa County and surrounding counties. But this is still being discussed at different levels. So yeah, the idea is to scale up the activities regionally. But yeah, ultimately it would be nice to have an ecosystem where different pioneers can cater to the needs and reinforce the capacity in different counties and regions, of course. Yeah. And the second question, I'm not sure I.
Doc, he asked what he asked was, what were the challenges you encountered while registering your Pioneer program here in Mombasa?
Okay, thank you. Well, the import process was the most challenging part for us, but as of registering the Pioneer as an official lab, within network of labs in Kenya, we managed to do so. It has been recognized as an official facility to work alongside other facilities. But yeah, we still haven't been able to integrate it into the NHIF network. So any services offered by the Pioneer cannot be reimbursed by national reimbursement program. So that's the limitation that we encountered so far. We are exploring again options to adhere the Pioneer to a specific health facility, so to, for example, Coast General Hospital, so that these facilities can be officially linked, and therefore this limitation could be addressed. But we are still exploring this with our partners on the ground. Yeah.
Thank you very much. Sige?
Thank you. Yeah, thank you. The caveat, of course, is I was presenting on behalf of someone, so I had to take some time. So the question was specific to GeneXpert, and basically what is known is that for TB meningitis, it's actually not very sensitive, about 50%. But the 100 comes in when they say, you know, when you compare now with culture, it's actually more sensitive than culture. So, you know, obviously those who are users of GeneXpert can comment more on that in terms of what the experience is, but that's the experience of the team at MTRH. Yeah.
It's possibly a typo. Maybe he meant sensitivity is less than 50%, but specificity would be quite good. Any other questions? Okay, I think, oh yeah, we have one question here.
Hello, my name is Doreen from Kijabe Hospital. I don't know who to direct the question to, but I'm getting to understand Biofire for the first time. So I want to know the principle behind it, and this is like one cartridge, or I don't know if it's a cartridge or anything, that is detecting several panel of infection. So I really want to know, how does that really work?
Thanks. It will be interesting, especially for you. We have a panel for you. It's called the Joint Infection Panel, which maybe we'll be presenting a little bit later. So, but just to take you through on how it works, yes, it's a PCR. I could say it's like a fourth generation PCR. You know our normal PCR procedure. You need a room where you do extraction, you need a room where you do amplification and probably detection, right? Again, the normal PCR procedure that we know takes probably maybe 2 or 3 hours, 4, even up to 6 hours, yeah? Like when we're doing the COVID test, how long would it take? Probably even up to 8 hours, depending on which methodology you're using. So with the Biofire, it's PCR, yes, but not singleplex, it's multiplex, meaning you are detecting quite a number of targets. Like for example, with a respiratory panel, you are targeting up to 23 different organisms at the same time. So all of it, all the your control and even the organism, you all analyze them all together. Of course, it will do a control. It's an RNA-based control. It will check against the RNA process, and then it will do a reverse transcription and check against the DNA, also the DNA target organism. So you kind of diagnose all of them. You'll do your extraction, amplification, and detection in one run within 45 minutes. I don't know if I've made sense, but there's a short video which maybe we'll be able to share during our presentation. Yeah, I don't know if it makes sense, but purely it's a PCR solution, only that it has improved now from the usual, we know, maybe up to 6 hours to 1 hour. And if you look, one of the banners outside, we are yet to launch same procedure, but will be done in 15 minutes.
Dr. Mutai. Dr. Mutai talked about the global fever panel. Is it in the market or it's in development? Maybe you can comment about that.
So the global fever panel, it went through the clinical evaluation and it has gotten the FDA approval. Edwin and his team will tell us when we are getting it in our labs.
Thanks for that, Dr. Mtai. One of the things I want to say, we are proud because this panel was actually validated here and their team in Uganda, IDI, Institute of they call it Infectious Disease Institute in Mulago. So we are very proud that this solution was actually one of our teams together with Professor Itumbi and Dr. Beth that who really came up with it. Now, if you look at the panel, it has some target organisms that Ebola, Marburg, Leptospira, Chikungunya, and Dengue. So for now, it will come out, but with a target that of clinical use. However, if you are a research institution or you want to do a research, you can still get the whole panel with all the targets. But take note, it will only be for research use only. Even now, if you need it, it can be available, yes, but only for research use only. We may not take any responsibility if you're using it for clinical use. But as Dr. Mutaya said, yes, it is out. And we just got the FDA approval. In Kenya, we should be launching it either in, I think, Q3. Dr. Sige? Yeah, should be in Q3. So it should be out by Q3. So this Q2, starting April, we are doing the market evaluation. Then in Q3, we roll it out.
Thank you for that. Does any of these kits contain HIV? HIV still continues to be a major problem, especially acute HIV, fever. Where are we with these ones?
Yeah, so we don't do, so far, no HIV, no hepatitis. Yeah, but it's feedback we can give back to R&D. And maybe to your question, Dr. Munyu, yes, for the pneumonia panel, there are some improvements. Maybe in the next version of pneumonia panel, you could be saying, it's a hard word for me, stratonomophonas. Yes, it should be in the next panel. Hopefully, we also think probably pneumocystis will also be there. So we are waiting for the new development in the next panel. But just to answer your question, HIV, not yet, and hepatitis, not yet.
I am inviting other questions. Yeah, okay. I'll invite Dr. Sigei back to the front so that he can direct us on the next step.
So thank you very much, Dr. Munyu, and thank you, everyone. We just had to excuse Dr. Adil briefly. He's coming back, and we really wanted his presentation before lunch so that the program, we try and catch up with time. So just give us a few minutes. He's rushing back up so that we can continue the program. In the meantime, if there's any general question, I think one thing I'll add is that we will have a comprehensive biometric presentation that will answer a lot of the questions that have been asked even during this session. So that presentation is immediately after lunch, and we then hope we'll be able to address most of the questions around the solution itself, the panels, what's available, what we are doing to ensure that it's available in more and more facilities. There was a question earlier about outside of Nairobi. At the moment, yes, it's very concentrated in sites in Nairobi, but we're working to expand that systematically to other towns. We actually have it in Mombasa, for example, and we're in the final stages of getting in Kisumu. Of course, MTRH, as you saw, has, which means Eldoret is covered. So it's something that we are launching progressively, and you'll be seeing more and more of it available across the country. So just stay tuned for the biometric presentation, which will highlight a lot more detail on that point. So I don't know if there's any other question, maybe online or in the room, as we wait for Dr. Adil to come up. Yes, Edwin, Dr. Edwin, I can see your hand is up. Maybe you can have the mic so that...
Right. Thank you again for these sessions, and Dr. Aweru, thank you for your presentations and sharing. From a different protocol elsewhere, there's a team that I work with. We've been examining causes of death, where we have a multiplex PCR diagnostics, and we are struggling with mycoplasma and ureaplasma, identifying the pathology of those two organisms and their contribution to respiratory pathology. Dr. Aweru, do you have any experience in that area? What have you seen with those two organisms? Then the challenges we have is that we do not have other reliable techniques beyond PCR to visualize the organism beyond PCR and electron microscopy. And we do see them detected quite a bit in many cases. We have challenges identifying whether these are true positives or false positives as well. Right, over, thanks.
You are right. The organisms which used to be called atypical pneumonia are very difficult to diagnose, and indeed things like mycoplasma still are a major challenge. It's possible now with this simplified PCR in future we may have better ways of diagnosing those conditions. I don't know whether biopsies will help, because we've recently launched quite a good program for doing lung biopsies. We are using cryobiopsies, so we can get very good tissues which can be subjected to genetic studies, DNA studies, and so on. So if you would like us, you are dealing with postmortems. Now there I won't show up. But with living patients, we'll be able to give very good tissue to researchers like yourself to look at these things. Thank you. So now I'd like to introduce Dr. Adil. He has like 16 prefixes and suffixes, so I need to read all of them, give him the due. Dr. Adil is a pediatrician, ID pediatrician at the Aga Khan University Hospital, where he's also a senior instructor. He has MPH qualifications and is involved in multiple research projects, both at the university and elsewhere. And we would like to invite him to do his presentation. You ready, Doc? So he's going to do a very important aspect of all this Biofire use, where he'll guide us on which patients do we subject to this test. Because it's a fairly expensive test, we need to be able to choose the right patients. Thank you, Doc.
Yes, as Dr. Aweru said, the topic of my title is, of my presentation is judicious use of syndromic testing, and this is more of a pragmatic approach. So I'm not telling you that these are the criteria and this is how you will pick your patients, because there are no guidelines even in the West for most of these panels, the multiplex PCR panels. So a lot of hospitals have adopted their own way of approaching this test. So this is just give you an approach of what maybe can be considered if you are faced with a patient, and how do you decide which patient should get the test. So the background we need to have a background of why we need to do the test. You know, it's not that we're doing the test for the sake of doing it, and these are all the factors we usually consider whenever you're making an antimicrobial selection. we have to think of what are the clinical skills and knowledge the prescriber has, what are the local guidelines advising on the particular diagnosis, the susceptibility patterns, what diagnostics do you have, and then what are your basal MDR rates, and based on that then you select your antimicrobial. And this is just showing you a diagram of, a map of OXA48 resistance, which basically means ESBL. And you can see that it's, and this is slightly old, but most worldwide now, it's actually quite endemic in most critical care settings, and even now beginning to be seen in the general wards. So why do we need rapid diagnostic testing? You can see this is a standard way of collection. So you'd collect a sample, start empiric treatment, send it for incubation. It takes at least about 24 hours if something is going to grow before it's flagged in the bottle. And then a gram stain will be done on that. And then now that will be cultured again, subcultured on a plate. And then susceptibility done once you have identified the organism. So that alone takes another 24 hours. And this is a best case scenario. So even on a best case scenario, maybe the earliest you can get is within 2 days, but usually it takes about 72 to 96 hours to get your result. And then based on that, then you will de-escalate or escalate your antibiotics. So the reason for rapid diagnostics, so you can see all the factors I mentioned there. So number one, delayed results. So we know, as you've already said, it takes 24 plus hours before the bacteria even begins to grow, and then another 24 plus hours before you have ID and susceptibility. So that in total takes about 48 to 96 hours of empirical treatment. So obviously if I had a rapid test, that 48 to 96 becomes much, much less. Yeah? I'm not going to stick to empirical treatment for all that time. So I'll be able to narrow down. And the longer you're on empirical treatment, if you're in inappropriate treatment because you don't have the diagnosis or you don't have the right pathogen, it could lead to mortality or morbidity. And then if you're treating with a too broad spectrum agent, we're also worried about resistance. Then number two, some of our cultures or tests that we do are unable to detect some of the causative agents. So for example, viruses, fungi, and some bacteria as well. And what does that mean? Sometimes you have a patient in front of you and you're not sure this is viral, bacterial, fungal. You make a diagnosis and you say, oh, but let me just cover for bacterial in case, because you don't have confidence in your diagnosis, and the patient may be sick looking, there's pressure from parents, there's pressure from the family, so unnecessary antibiotic use when you have viruses. Number three, even the best tests, you will not be able to, with the best treatment, you might not be able to recover the pathogens, especially if they've been on broad spectrum antibiotics. Yeah, so we see this often. They've been pre-treated either in the outpatient or where they're coming from, or even sometimes like when you have a meningitis patient, you won't have that opportunity to do the test before starting antibiotics. So in that case, you're most likely going to end up being on empirical treatment, and the entire duration will be on empirical treatment. So can rapid diagnostics help you there? Most likely, yes. Yeah, I would say at least in the majority of cases, you'd be able to make a presumptive diagnosis based on your rapid diagnostic result. And then lastly, people continuing on empiric broad spectrum therapy despite test results justifying de-escalation. And here we know that the problem is that people on empirical treatment and they don't want to narrow down, they're like, the patient is doing well, let them finish this. Yeah, that's what happens when you're in the clinical practice. My patient is doing well, I don't want to change anything. Even if your result is showing this is maybe a strep pneumo, amoxicillin would be good enough, ceftriaxone, you're like, no, let's continue on the meropenem because my patient is improving. So, where there's evidence, people still don't follow evidence. So maybe rapid diagnostics could help. We don't know, their education is also needed. So antimicrobial stewardship is what we're driving at, and it's been shown that rapid diagnostics is now a part of antimicrobial stewardship. So the earlier you can make a diagnosis, the more likely you will narrow down, you'll use less broad spectrum antibiotics. And what can rapid diagnostics do? So this, I think, it's been mentioned the whole of today. You can get the organism, the type of bacteria, the resistance, and in some cases, in some tests, you can also be able to arrive at susceptibility results. But we're saying all these tests need to be done with stewardship, okay? So not everyone will you say, I want to do a multiplex PCR panel because I have the test available to me. You have to make an informed decision. You have to look at who's in front of you, what does a patient have, and then make your decision based on that. So this is a paper in the Journal of Clinical Microbiology, and it talks about the role of diagnostic and antimicrobial stewardship. So just a statement there that I'll read. We need also diagnostic stewardship along with antimicrobial stewardship to ensure that these technologies conserve rather than consume additional healthcare resources and optimally affect patient care. So this, Dr. Sigei mentioned that we had a meeting with the insurer, the payers, this week, and it was actually very eye-opening for us because we never really thought of it from their perspective. Yeah? So one thing they mentioned is that the average person who's insured, their premium for a year is 40,000 shillings. And that's the average, majority of the people. And we know that most cases, Biofire is either around there, even maybe more in some cases. So when you order one test, that means that's used up all the money that probably came from that patient. Just that one test alone. So we're not saying it shouldn't be done, but we should do it with wisdom when it's needed. Because when you use that test for that one patient, other patients probably will not get the cover that they need, or you'll find that no, this is not being covered, the insurer is fighting back on other things for other patients. Because they have a limited resource, so we also have to think of what resources are we using and when do we use them. So this basically shows that they're interlinked. Diagnostic and antimicrobial stewardship are interlinked. They rely both on what the patient has and the lab, what your lab finds. So when you do diagnostic stewardship, oh, the slides are not moving. Or what happened? Sorry there's a technical glitch for the online viewers. Okay, sorry about that. So we'll continue. So what do we mean about diagnostic stewardship? So we're saying doing the right test in the right patient at the right time. Okay, so you have to think about all those factors when you're deciding to do a test for any case, not even for Biofire, any test that you do, whether it be a CBC, be it CRP, a culture, whatever is indicated, you have to justify, meaning it was the right test for this patient and it was done at the right time. Yeah? So for example, if your patient had fevers and a running nose and maybe had upper respiratory symptoms, and 2 days later they present to you and now they're doing better, I don't think you'd be able to justify doing any test at that time. Yeah? So you have to, it's not that we just do tests because we have them, we should think about when we're doing them. And then that now we're saying with the right tests, it informs informs your decisions, you get your diagnostic results early, and based on that, if you interpret them correctly, you administer the right antimicrobial at the right time, and that leads to antimicrobial stewardship, which also then leads to better outcomes. To use them all. Okay. Yeah. So I won't mention this. I think antimicrobial stewardship we're quite aware of. So diagnostic stewardship, also I've mentioned this, doing the right test in the right patient at the right time. So this has also been mentioned today. I'll I want to go more into the examples that we have of the individual tests. But whenever you have a diagnostic stewardship question, it's not just you as a clinician, so you have to put into consideration everything. So first of all, you as a clinician are the end user of the test, meaning the other factors that have happened, and the hospital or the facility you're in has allowed you to order this test. And then the administration are the ones who facilitate the test. So meaning they're the ones who bring in the machines, the reagents, they are the providers or the bigger providers for the test. And then you have the microbiology lab who should control the test in terms of when is it being used, the results that are being released, and how to interpret it. So it's a mix between all three players, because you want the hospital administration buy-in to know when the test, to allow the test to be there, the clinicians to order the test, and then the microbiology element, which is controlling the use of the test, or at least facilitating in the right patient. Okay? And then if, just the same way we have concepts for antimicrobial stewardship, we also have similar concepts for diagnostic stewardship. So nudges, meaning, behavioral interventions that help clinicians to make a decision. So it can be a prompt that comes up on your electronic system telling you, before you order this test, have you also thought of this? Or this could be a viral infection based on your diagnosis. Do you want to proceed with this test? And then other things could be best practice alerts, so like having guidelines that are put up in the units and saying, this is the standard of care for this, when you make this diagnosis, you should order these tests and you should not order these ones, these are not recommended, and maybe these are the patients to consider if the patient is not improving. And then removal, so sometimes you might have to remove low value tests, because you'll find that people keep ordering them and adding to the cost for the patient, but they actually have very little value in terms of what is in terms of decision making for that patient. Okay, and then inclusion, I think it can be included in an order set. So if those of you who have worked with electronic systems, you know that if you have a certain diagnosis, for example, gastroenteritis, you'll have an order set that comes up and it tells you all the tests that are part of that order set. And that kind of takes away the option of, it doesn't take it away, but at least it makes the clinician follow what is within the order set. So you don't put in some tests into your order set and some you put in. And then stops is, for example, even if the test is testing for Clostridium difficile, for example, as mentioned here, but you don't have to report it. Or you can even remove the test altogether, or you can put a stop if, for example, the patient comes in at admission or has been in hospital for long and there's no diarrhea, and then you order C. difficile test on that patient. So that really doesn't make sense in a patient who doesn't have diarrhea. Okay, and then reflex testing is, for example, when you have a patient with meningitis, and that's what's being done in many settings, that they'll only allow you to do the panel when there are certain parameters that are met. For example, there's a white cell response, or maybe proteins elevated above a certain level, then they'll consider it. But even then, it's reflex based on certain conditions. Okay, and then result suppression, we've mentioned that, and then monitoring your usage. So diagnostic stewardship is not easy. It's hard work, and who is going to be the owner of that? So it's something to think about. So now we'll go into diagnostic stewardship for the different panels that we commonly have in our facilities. I think pneumonia panel is relatively new in our setting, and it's not being used as much as the other panels, because I think it's only certain physicians who will use it, so it's not such a problem yet. But the main ones that we'll talk about are the respiratory panel, the ME panel, and the GI panel. And some of the things that were mentioned by Dr. Kigu in his presentation we'll also see here with regards to the GI panel. So the syndromic respiratory panel, where is it used? So it's useful for patients in terms of identifying their disease. So what are they presenting with, and giving them a name, giving their disease a name, which helps them to understand and helps them to accept the kind of treatment that you give them. And it also allows you to start effective therapy. And then, for example, if you get a positive viral result, you'll be confident in stopping antibiotics. And then it also helps with infection control. So, for example, if you isolate pertussis, influenza, COVID-19, you know how to isolate those patients, and then which patients actually even to avoid meaning they will not room them in together with, for example, a hem-onc patient will not be roomed in if someone has even adenovirus or something, because the risk is higher. So I'll not mention this. So how do you decide whether to use a multiplex PCR testing in respiratory tract infections? So we have given different settings where you can use it. So the emergency department implies it's different from the outpatient. So it's an emergency where someone is coming in a critical state. So we're not talking about those who are coming for a cough and cold, the one who has generalized pain, non-specific pains. That's not the emergency. That's the outpatient. So emergency is those in a critical state and who are most likely going to be admitted, but now they've presented in the emergency. So in that setting, if they have respiratory symptoms, it's advisable to do the respiratory panel, because those are patients who will most likely benefit from whatever result you get. Yeah? Even if it's negative or positive, it can help you make a decision if it comes, whenever the result comes back. And then especially if it's point of care, remember these patients are very critical, so you want something as soon as possible to be able to help you make that decision. In the outpatient, it has high value in high-risk patients, okay? So I wouldn't do it for any other patient. You're normal, healthy adult, healthy child. You do not need to do routine multiplex PCR panels for them. But those who are high risk, so we're talking about those who are immune compromised, your cancer patients or transplant patients, those are the ones that would fall under this category. In inpatient, it's been shown to be especially useful in pediatric patients, because pediatric, as you know, are the bigger carriers of viral infections. So there you can use that test for your IPC measures to know who you'll separate, who you'll cohort. So it can help also control infections in the hospital, and it helps with antimicrobial stewardship. So it's recommended to do in some settings, but the guideline or the studies that have shown that in inpatient doing it for everyone has not had the benefit that was intended. But maybe it's lack of education, as we said. Even if you get a result and the clinician says, I want to continue the antibiotic, the intention was that the test is supposed to help them make that decision, but unfortunately that's not happening, and maybe that's an education aspect that needs to be worked in. And then obviously ICU patients, it would be useful, especially those who maybe lower respiratory tract specimens might be difficult at that time to obtain, and maybe you want a quantitative result for a certain virus or a certain bacteria. You can use that, especially from the upper respiratory panel, if you're suspecting maybe they have a viral infection, okay? So the goal of using this test in viral upper respiratory infections is, as we said, it helps you to, it's a satisfactory and sufficient real-world approach to minimize diagnostic uncertainty. So that's where it's used, where you have especially diagnostic uncertainty. But if the patient is looking to you like a typical viral respiratory infection, a common cold, then where you have an obvious diagnosis and the patient is stable, that's not the patient for whom this test is needed. And so as we said, right patient, right test, right patient, and right action once you get the results. And then, so some places focus on an algorithmic approach. So what does this mean? So if patient comes to the emergency or ambulatory care with influenza-like symptoms, so an influenza-like illness, they say start with a rapid diagnostic test. So some facilities have that option where you can do a rapid diagnostic test for COVID, for influenza, and sometimes even for RSV. And if the patient is looking like they have influenza-like symptoms and they're positive, that confirms your diagnosis. If they're negative, then you can still go ahead and do the multiplex PCR, because it's more sensitive and it allows you to test for multiple pathogens, even the ones that are not in the rapid panel. So this was just what I was talking about earlier. So it says that it should use of rapid viral testing, and it should be used in, especially in the inpatient, to reduce inappropriate antibiotics. However, there's a study that showed that despite that, it has a potential, but studies have not been able to confirm that, because with just alone, it's not enough. So you need some antimicrobial stewardship program in conjunction to convince prescribers to change behavior. So remember, we said it's a behavior problem and not diagnostic problem. So this is a case, 63-year-old male, known to have severe COPD. presents with fever, cough, malaise. He's tired looking, he's in mild respiratory distress, he has diminished breath sounds bilaterally, so his air entry is not that good. And then, so you've put him on oxygen, 2 liters via nasal cannula. He has shortness of breath. Once you put him on the oxygen, his shortness of breath has remained stable. Oxygen saturations pick up to above 90%. So the chest X-ray, you can see it. It was done at admission. He has hyperinflated lungs, but no definite infiltrate. So nothing to suggest a bacterial cause for this patient. So his lab results are essentially normal. ECG does not suggest CVS cardiovascular event. So in this patient, would you order upper respiratory panel? Any takers? Anyone who wants to try? 63-year-old patient, COPD, comes in with fever, cough, malaise. Okay, let's assume it's done, okay? So you do the test. And it comes back positive for metapneumovirus, and they start the patient on azithromycin. So remember, this is COPD, so I think as per their protocols, they usually will give azithromycin even if there's no bacterial pneumonia, because I think it's associated with exacerbation. So, but in this case, respiratory panel was useful because you could arrive at a diagnosis. Yeah. So remember, COPD is not your normal patient, your immune competent, healthy patient walking around. They're at higher risk than the other patients, and they may not have classical signs and symptoms. So if you can arrive at a diagnosis and it's compatible with what they have, it helps you to then make decisions. So they didn't need broad-spectrum antibiotics. They weren't treated as a community-acquired pneumonia, and you could discharge them with that diagnosis and tell them to continue with the azithromycin. The next is a 9-year-old girl, has high fevers. She's coughing, she has a running nose, and it started the previous evening. She appears flushed, ears are clear, examination is unremarkable. So mom says many of the girl's friends are sick, does not know if they've been tested. So there are many of them who are sick, but she doesn't know what they have. Okay? So would you do an upper respiratory panel for this patient? Would you? We're talking about the full panel. You can, there might be something else you can do before the full panel. What's her diagnosis looking like? It's influenza, yeah? It looks like influenza. So if you have the option, you should start with a limited respiratory panel, if you can do that. So where you can test for specific pathogens such as influenza, SARS-CoV-2, or RSV. Yeah? If you have that, start with that. If you don't have that, that's a different issue. Then you would go for your multiplex panel. But where you have a limited panel, where you can test specific pathogen, and it's looking like influenza, then you should start with that. And then, for example, in this case, they did a limited panel, it was positive. So she was managed symptomatically and given oseltamivir. Okay, so based on her presentation and history, likely viral and full syndromic panel was not necessary, unless you see if she was otherwise, she had other immune deficiency issues, and you're worried you might miss something else, or she might be at risk of atypical pneumonia, but she didn't have any of those features. Next is a 58-year-old female. She's in respiratory failure, requiring high-flow nasal oxygen at 60 liters per minute, and her FiO2 is 80%. She's doing well on immunotherapy, but until 2 days ago when she developed a minimally productive cough and fever. So her oncologist sent her to the emergency department. Okay, so this is a patient who has some hem-onc issues, and she now comes with a 2-day history of productive cough and fever. She appears anxious, and she's using some accessory muscles. So her history, as is written there, lung cancer metastatic to the liver, and she also has advanced COPD. So a rapid test is done, it's negative. Chest X-ray that was done initially showed bilateral patchy infiltrates, and there's also ground glass opacities. And the CT scan, you can see it there. basically just showing the bilateral ground glass opacities. And on examination, she has bilateral crackles. Her labs just show a bit of prerenal azotemia, mildly increased white cells, and predominant lymphocytes with very low platelet count. So, what do you think? Would you do an upper respiratory panel for this lady? Would you? Alone? Okay. Yes. So I think this lady warrants it. Remember, she's a cancer patient. She's on immune suppressive therapy as well. Yes. So she's at high risk of even viral infections causing severe disease. Yes. Unlike an immune competent person who you wouldn't expect, even if they had a viral infection, to deteriorate. So in her case, because it looks like a viral infection, even looking at the CT scan. Okay. So remember, she's on immune therapy, and you're thinking, okay, could this be immune therapy-induced pneumonitis? Could this be progression of a cancer? Remember, she also had lung cancer. Or is this an infection, what we're thinking of? So the panel is ordered for multiplex PCR, and it comes back positive for adenovirus. So adenovirus can present exactly like this, especially in those who are immune compromised. It's not unusual. Yeah, so you have a diagnosis, then you can safely say, oh, this is definitely, it doesn't look like bacterial, and you have a result that also confirms it. So you manage symptomatically, and she's given oseltamivir for the same. Although the reason for it might not be the best, but so there are not many options for adenovirus. Okay, so just some thoughts about the respiratory panel. And as we said, this is a pragmatic approach. I'm not saying these are how you would decide, but when you're making your decision, you'd want to think, is this patient otherwise healthy, or are they immune compromised or critically ill? So maybe if they're otherwise healthy, I would be a bit hesitant before ordering. But if my result comes back and it'll change my decision, then maybe that's a good test to do. If I'm not going to prescribe antibiotics, if I don't have the option of doing an influenza test and this is all that I have, then I could do this. And sometimes, yes, if you have targeted testing, you should start with that based on their presentation. And in some places where there's seasonality, you can use that to decide. So the next is CNS infections. Here we're talking about the ME panel. So when you're using the ME panel, the guidelines generally use a team approach. So what do they mean? That involve the microbiologist, involve the ID specialist, involve the physician who's managing or the hospitalist, and based on your initial CSF parameters, then you can decide whether to do the ME panel or not. Yeah? Because some guidelines say if the white cells are less than 10, there's no point of ordering it. Although there is enough evidence, or there are some cases where even with the normal white cell, they actually had a positive finding on CSF for things such as HSV and enterovirus. And unusual for bacterial, but for viral cases, it's been found. Yeah? So if you're testing lots of CSFs to find rare CNS infections, need to ensure that the positive results are interpreted and acted upon quickly and appropriately. So what does this mean? So with targets that require additional knowledge, for example, HHV6, CMV, human paracovirus, you need to know what you're going to do with that information, and if you're going to make any decision based on it. Remember that there are some limitations of the ME panel that need to be understood. So it first of all does not include all the possible causes of meningoencephalitis. It just includes majority of the causes, and it's I think about 80% of whatever causes meningoencephalitis is covered. The rest of the 20 are mostly viral causes, which most of the time you wouldn't even do anything about, unless it's something else like West Nile, where maybe you would give them steroids, but just those are rare, and in our setting we don't see them. Should not be used alone. It should be used. So culture should be done first, and it should be used as an add-on tool to that. And then it has lower sensitivity for HSV1, HSV2, and Cryptococcus neoformans. So yes, we said it's high sensitivity and specificity, but if you compare it alone to HSV1 standalone test, or HSV2 or Cryptococcus, it's a bit lower than those three. And then it should not be used for nosocomial infections, because it's very unlikely that nosocomial infections will be caused by the things that we're talking about on this panel. So it's best used in targeted populations, so especially in infants under 2 months, or in encephalitis patients, those who are presenting with typical features of encephalitis, and then, as we said, those with CSF pleocytosis. Okay, and in this case, it's actually cost effective because you don't have to test for different individual pathogens. You're testing for a multitude of pathogens, so within one test, so that saves you significant cost. So this is a case of a 9-month-old boy. He had fevers and headaches. He had signs of an ear infection. He was seen in the outpatient and treated with amoxicillin and sent home. So he represented with, a week later with fever, stiff neck, and vomiting. So looking like now he has meningitis. And was it possible he had it before? It's hard to tell, but it should have been considered at that time. So a spinal tap is done. It shows CSF pleocytosis, and gram stain is negative. Unfortunately, this facility does not have the ME panel. So he's transferred to another facility where he has seizures with worsening mental status. He started on broad-spectrum antibiotics, but cultures remain negative. So remember, he had done almost 1 week of amoxicillin, so we don't expect his cultures to be positive either way. So he's continued on those antibiotics through a PICC line to complete 3-week course for suspected bacterial meningitis of unknown etiology. So in this case, if you had an ME panel, would it have made a difference? Probably, because you would have had a diagnosis. Yeah? Even right up front, you would have had the pathogen, because even with antibiotic use, bacterial meningitis would have been, you would have found it positive in this case. Yeah? Because the PCR can remain positive even up to 2 weeks later. So it's not unusual to pick it up, and even in a patient who's been treated. So in this case, it would have been useful for someone who has received antibiotics. Yeah? So where your culture has limitation, your multiplex panel doesn't have the same limitation. The next case is of a 5-month-old girl. She presents with 8 hours fever to 40.2 degrees. So she has very high fevers. She's irritable, difficult to console. She has a macular papular rash generalized over the whole body. So now you're obviously thinking, okay, she's irritable. We're worried about meningitis, encephalitis. So your list of pathogens is numerous. Group B strep being high because of the age. Listeria, gram-negative rods even because of the age. Strep pneumo, Neisseria, Haemophilus, HSV1, HSV2, enteroviruses, human parvovirus. Any of these can cause this. Yeah, so in babies, they don't have typical features of meningitis. They will have sort of an encephalitis, and even that is very difficult to elicit just based on the history. So I'm going to tell you what we used to do in the traditional route. So you'll do the lumbar puncture, send the CSF to the lab for gram stain and culture, cell count, protein, glucose. And then if you had the option for enterovirus, it usually was a send-out. You'd send out to another lab. And Pericovirus generally is not available as a standalone test. And so the patient is with you for 7 days, and maybe results come back then. So for 7 days, you're on empiric treatment for meningitis. You don't have a choice. You're going to treat this baby because babies, we know, are not, they don't respond as adults, or you can't take them that lightly, so you have to be more cautious. No one would be that brave and just say, oh, send this patient home. We know for sure this is not bacterial. Yeah. So in the syndromic method, you do the LP and you send the CSF to the lab, and within a few minutes, 90 minutes, you get your result back. It's Pericovirus. Yeah. So you can stop your antibiotics, tell the patient this is viral, tell the parents this is viral, and it will resolve by itself. You just need supportive treatment. So you send them home the next day, and you ask them to come back for a follow-up visit. So you can see in this case, it was warranted. Yeah, something that you would not have if you didn't have the option. You can see how much of a difference it makes in terms of management, in terms of how long you'd keep the patient there. The next case is a 22-year-old previously healthy female. She presents to the emergency department. She had 2 days of fever, temperature of 38.5 degrees. She has headache, neck pain, stiffness. So you're beginning to think maybe there's meningitis. She's also vomiting. So an LP is performed. Not very remarkable. White cells of just 450 red cells. So slightly traumatic. But now in this case, they did an ME panel. Yeah, and it came back positive for HHV6. So So unfortunately, they said, okay, we want to treat the HHV6. So she's admitted with a diagnosis of HHV6 meningitis. And as you know, HHV6 doesn't commonly cause meningitis and encephalitis in immune-competent hosts. So it wouldn't be a worry in this patient. She's previously healthy. She has no features suggestive of immune suppression. So you would really, maybe in this case they made that decision, but it was a bit of a light call for her. So during her stay in hospital, she's on IV fluids, NSAIDs. However, her fevers still continue. Yeah? So you're not given antibiotics, you're just continuing with the treatment for HHV6, which usually is a cyclovir. Her fevers continue, neck pain continues, she's unable to take orally. So now you take her CRP, it's 12.6, it has slightly gone up. In view of her inability to swallow, she's in significant pain, you do a CT of the neck, and it comes back as a retropharyngeal phlegmon. Yeah? So it looks like it was a retropharyngeal abscess that was there from the word go. So she started on IV antibiotics, and her discharge diagnosis now is deep neck space bacterial infection. So you can see sometimes the multiplex panel or having a test does not help you in making a diagnosis. Yeah, so this is an example where it made a negative impact. Because you were so confident that this is HHV6, you probably did not examine properly, you were a bit confident, like, no, this is fine, we'll just manage and give her time. But you missed some of the obvious signs. Yeah. So, because her presentation for this abscess or retropharyngeal neck space abscess would also have been similar to someone with meningitis. They have neck pain, they have stiffness, they're having headaches, it's very typical. They would present similarly. So it's not always that a positive result is a good result. So sometimes you have to take it into context. And that's why we said the ME panel, you need to have teamwork, you need someone who can guide you on whether this is truly HHV6 or is this just, because HHV6 is like any herpes virus, they remain latent in our white cells. So it's not unusual for them to even be shed at later times. The last case in the CNS panel is a 66-year-old man. He presents to the ED with confusion. His history, his back pain for past couple of days, he's very sleepy, he's not acting like himself, he has soaking night sweats but not reporting fever. And given his low GCS, he's intubated in the ED. Other pertinent information, the patient looked very ill upon arrival in the emergency, neck was a bit stiff, pupils were not reactive, and he was not reacting to noxious stimuli. His labs, white cells are mildly elevated, but he has significant left shift. His hemoglobin and platelets are normal, creatinine is slightly elevated, procalcitonin is 26, and CRP is 53, so a bit high for both. So imaging studies are done because you're not sure what's causing all this. So a chest x-ray is done, showed some atelectasis. A CT scan of the head is done, did not show anything, just a bit of ventricular prominence. Full body CT scan is also done given his night sweats, and there's concern for TB, which was also negative. So a lumbar puncture is planned because now you're thinking encephalitis. We need to make sure that we look for things, especially like HSV 1 and 2. So should this patient get a ME panel? What do you think? Remember we said, what are the conditions? We said if someone presents with what looks like encephalitis, you should ask for the ME panel. Because there's no other test that you can do, unless you have a standalone test for those viruses, but even those take time. In this case, you'll get your result quickly, so we recommend that you should do an ME panel. Because although it looks like encephalitis, this actually turned out to be strep pneumomeningitis. Yeah, so white cells were not very high, surprisingly, just 113. Glucose was low, protein was very high, gram stain was negative, so it didn't pick up anything in gram stain, and your multiplex panel actually came back for strep pneumo. Yes, sorry. CSF, in CSF. It's 113 in CSF. It's high, but not typical of bacterial meningitis. It would, if I saw this, I would say most likely this is viral, but then the polymorphs are high in that, so you would think maybe it's high, yes, in definition it's high. But for bacterial, usually you see up to 1,000 even. Yeah. So the multiplex panel came back shortly, positive for strep pneumo. CSF cultures also grew strep pneumo, but this, it would have taken quite some time before you got your cultures back. Okay, so you're able to make a decision. So the patient initially was on empiric vancomycin and cefepime, covering for both gram-negative and gram-positive meningitis. So once the CSF results came back initially, so it was transitioned to vanc, ampicillin, and ceftriaxone, because now they're also worried about listeria. But then as soon as the ME panel came back, ampicillin was stopped because it was not listeria. And then once the culture results came back, the ceftriaxone was also, vancomycin was stopped, and the patient was continued on ceftriaxone. So just some thoughts about the ME panel. It obviously allows you to do rapid identification, and that makes a big difference. And you can transition to the right drug as quickly as possible. So in meningitis and encephalitis, hours really matter. Yeah? You know that makes a big difference. Having the right diagnosis up front can make a big difference in the patient's lives. And as we said, optimal use is still a work in progress, as we said, because there are those guidelines that say you have to have some pleocytosis before you can use it. There's certain criteria that you need to fulfill. So they've been shown that some patients will still fall through the cracks if you have those strict guidelines. So for ME panel, it's very subjective, because this is something that, the patient's life is critical in that time. So someone who makes that decision would be very brave to say no. So syndromic testing in GI infection, so this is the last one we're going to talk about. The basis for this is that diarrheal pathogens all have similar presentations. I mean, generally, especially for the bacterial cases, it's very, very hard to tell them apart. Maybe fever is more seen in Campylobacter, Shigella, and Salmonella, but even that, you'll still have patients with E. coli diarrhea who will also have fever. But otherwise, the rest of the symptoms are almost the same. So it's very hard to make a clinical diagnosis based on just a diagnosis just based on clinical symptoms. So challenges with the traditional methods, I think we're all aware. You need specific culture methods. For each of those, actually need a specific culture method. For Campylobacter, it needs its own, and then Shigella and Salmonella have their own, and then E. coli also needs to have its own culture media. And some pathogens do not survive well in transport media, so even as they're being transported, the pathogens will die, so you're worried that if the longer you wait, it's not going to culture that well. And then culture, as we said, is just time consuming. It's not an easy process. The whole to identification, to susceptibility, it requires a lot of manpower and resources. And then there are some assays that can detect toxins when needed. And then the big issue is that certain bacteria have contraindication to antibiotic treatment. As Dr. Kigo mentioned, especially a Shiga-like toxin producing E. coli, the O157, because of its risk of hemolytic uremic syndrome. And then obviously you cannot culture viral and parasitic organisms from stool, especially in clinical labs. So I think this we all know, its benefits. I won't mention this. I'll also not mention this. So sorry, this might be a bit small. I hope you can read it. So when should you use the GI panel? So similar to what Dr. Kigo mentioned, most acute diarrhea episodes in previously healthy, immune-competent people are of short duration and self-resolving. So you should think like generally this will resolve even if it's bacterial. We generally say lab investigations are not needed for most acute gastroenteritis patients, because it's going to be self-resolving. So in which patients would you consider the panel? Number one, patients with moderate to severe acute diarrhea. So meaning they're having dehydration, they're being admitted because of the gastroenteritis. Those are the patients maybe you would consider because it would make a difference in arriving at a diagnosis and administering the right antibiotic or the right treatment. Or in those who have prolonged GI symptoms. So when you think of things like giardia or other chronic diarrhea causes, this is a very useful test because it doesn't rely on the lab tech looking at the slide and trying to identify the giardia, or most often they miss it. It will pick it up if it's there. And then patients with dysentery, it's generally recommended. But the caveat for dysentery is because this recommendation is for the West, the rates of dysentery are low. Ours, they are a bit higher, but even then, if the patient can afford and they have dysentery, we should generally recommend it. And then immune-compromised, it should also be recommended. And then those who are in high-risk settings, so healthcare workers who can transmit to their patients, or those who work with small children and the risk of transmission to those children. So this is the first case, a 5-year-old boy, previous bone marrow transplant recipient, now presenting with diarrhea and abdominal pain. So you're thinking now, could this be GVHD, graft versus host disease, or is this infection? You can't tell just based on the clinical symptoms because they look exactly the same. And even both will present with fevers. So in the initial workup, you do endoscopy with biopsy, abdominal CT scan, rotavirus antigen test, norovirus PCR, stool culture, C. diff PCR, Shiga toxin, ovan parasite, and in some places they have the option of also doing the cryptosporidium and giardia antigen test. So all this workup, because this is a patient who's immune compromised, severely immune compromised, so you're really worried and you want to test for as many pathogens as you can, and they don't have the GI panel, so they're kind of stuck. So they do the initial test, all are negative, so they think, okay, maybe this is GVHD, so steroids are administered, but his pain gets worse. Pain gets worse, diarrhea even gets worse. So 2 days later is when the stool culture comes back positive, and it's positive for salmonella. Yeah, so because there's no way of knowing it before that this was salmonella, so the clinician thought this is GVHD because everything else looked negative. And then in view of that, then they decide to give antibiotics. This is around now day 3-4, and you can see because of that, the length of stay in hospital was a week. Alternatively, if your institution had a GI panel, as soon as they present to ED, you can immediately ask for the PCR panel, and it tells you this is salmonella. Yeah? So you didn't even have to give the steroids. That's why probably the patient worsened because of the steroids in immune compromise with an active infection. So you can decide at that time if they need antibiotics or not, because as we said, salmonella doesn't always need antibiotics. It depends on how the patient is doing. So at most you would probably need 1 night in hospital, whether you start them on antibiotics or not. And if they're doing well, you can discharge them the next day. So the next case is a 21-month-old baby brought in for vomiting and watery diarrhea for 8 days. So sick for 8 days. Attends daycare where it seems everyone has had vomiting or diarrhea this month, according to the parent. The child is, however, febrile and has not been hospitalized or received antibiotics in the last 3 months. So remember what Dr. Kigu said, if you test the stool, you will pick up many things. Yeah? Not always necessarily pathogenic. So in this case, you have picked up norovirus, astrovirus, and C. difficile is also picked up. So the question now you'll ask yourself, are these results real? Because now you don't know what is happening. And then why does a child have 2 viruses? Is this community-acquired C. difficile? Yeah? So remember what we said, that children, especially under 2 years, they're usually colonized with C. difficile. So it's extremely rare that they would have a true C. difficile infection. And a patient, community-acquired C. difficile is extremely rare as well, especially in children. So you would think 100 times before saying this is C. difficile. Yeah? So you have to take the clinical and epidemiological context into consideration. So normally we know that your diarrhogenic E. coli, they will cause diarrhea, but can also be found in a symptomatic individual. So it will be very hard to say whether it's truly pathogenic or not. And most of the time they're also self-limiting. And then as we said, C. difficile is now increasingly being found in the community, but asymptomatic colonization occurs and is especially common in young children. So most likely, given the presentation of this patient, this baby had norovirus, which is very typical with vomiting, a lot of vomiting and diarrhea. So the C. difficile was just likely a colonizer. And the astrovirus, so remember these are fecal-oral transmission. So these babies, when they're interacting with other babies, they're not only picking up the norovirus, they're also picking up other bacteria, they're also picking up other viruses. So it's very possible the astrovirus was also picked up in the same way. But given the presentation, it looks like norovirus. Astrovirus generally causes mild gastroenteritis. The next case is a 63-year-old male. History of a kidney pancreas transplant, presented with diarrhea for 6 months, reported approximately 10 bowel movements a day, making him fearful to leave the house. So because this is an immune-compromised patient, the risk of complication is very high. So you ask for the multiplex panel, EPEC is detected. Yeah? So based on that, because remember we said this is immune compromised, you would want to treat them because the risk of getting severe disease is high and complication is also high. So the patient was treated with azithromycin, which resulted in complete resolution of GI symptoms. So this just shows, this is a basic guide for when do you treat enteric pathogens. Yeah, so remember we said enteric pathogens are also carried asymptomatically. So testing should be done in those who, first of all, meet this criteria and are presented with a compatible syndrome. So if they're in severe state, so meaning they're dehydrated or admitted, those ones you would consider testing. If the symptoms have been going on for more than 7 days, you would test and treat. Immune compromised, you would not wait, you would treat most likely. And then if the risk of spreading to others was also high. So for example, if you found salmonella, the risk of transmitting to other patients is very high, or even something like cholera. So just some final thoughts. Sensitivity and specificity of GI panel is high. Rapid results can reduce inappropriate antibiotic results. However, testing should be limited to patients with appropriate clinical indications, i.e. in patients whom it will make a difference. You will be able to do something with the results. And in this case, we're saying a holistic approach of combining risk factors, clinical features, and syndromic testing allows for optimal patient management. So this is just an overall slide of all multiplex PCR panel. When are you going to decide this patient needs the multiplex PCR panel? These are a number of questions you should ask yourself. First of all, is the patient truly sick? Number 2, is the patient getting better? So if they're getting better, maybe I would think twice before doing the test. If you find something, would antimicrobial treatment change the course of the disease? So that would help you decide if you need the test. Will testing alter the choice of antibiotic? So if I'm going to change antibiotic, then maybe. And how does multiplex PCR correlate with patient symptoms? So also think about, if I get a result, is it matching to the symptoms the patient has? Yeah, so for example, we had the patient with the HHV6 meningitis. The patient factors, patient condition was not matching. So you would think, okay, even if I get a result, will it change my management? And then are there epidemiological limitations or implications to establishing a diagnosis? So for example, risk of transmission to others, that's what you would worry about. Thank you.
Thank you very much. I think that was fairly exhaustive. And if I may summarize, number 1, there is need for communication with stakeholders so that they understand what we are doing. Number 2, public participation has become the byword. Otherwise, you'll tell me to stop my antibiotic, I will refuse. Number 3, the use of algorithms. I think that was a very important aspect so that not everyone gets the test. And then, very well delivered, Doc. Now, I request for questions. Any questions?
Is it working now? Perfect. So again, thank you for that presentation. 2 broad comments. The first one, for especially those of us who work within the public sector space, we run a risk of having a situation where we have invested in multiplex PCR panels when we haven't developed the capacity of the other laboratory services that support it. And you've rightly said that you definitely will need cultures to be fairly well done. And the challenges I see, for example, 2 weeks ago, I had a trip to Uganda in one of the rural hospitals, a district hospital that's very busy, and you find a shining multiplex PCR platform with very good capacity, but nothing else to support it. So I still think the message should be that even as we build capacity to integrate multiplex PCR-based diagnostics, we should not leave the other specialties behind. And then we also run into a situation where you have individuals, maybe do not have specialists providing oversight. So you have individuals who make critical care decisions on a patient, and they may not have that training, so that capacity also needs to be developed and should not be forgotten, really. Then the second point, again, now that will be, I know Dr. Waris, you're a pediatrician, or am I confusing you with the different worries? hurdle anyway. So we now have another problem of underutilization, and because the basic pediatric protocols has, the diagnostic component is so low, so we definitely need to engage strongly within the professional associations to particularly look at that. But again, thanks for enlightening us with your talk.
Yeah. Okay. Thank you for those comments, and I agree with you about number one. I think the traditional methods are still our gold standard, and we have not said that. If you remember, in all our slides, we have culture always done together, and we feel like yes, those should be strengthened, and then Biofire is now an add-on. So, if your traditional methods, your routine cultures, microbiology lab is not functioning well, I think your priorities would be maybe to set that up first and then move towards your molecular testing. And yes, I think developing capacity both within the lab, within the clinicians, just how to use the test, how to interpret it, I think that's a given, and cannot be underestimated, the value of that. And I think that's a message back to Biomeru about when you have these tests and when you allow these tests to go to many facilities, what capacity do they have, first of all, in deciding how the tests are done, and then also in the interpretation, because if the tests are done, it's the same problem even with cultures, I guess, because when you have cultures, if you don't interpret them the right way, you'll still end up with the same problems. You won't know what to make use of those tests. So I think it's not only Biomeru, but in general, any test that's done, capacity is needed both in the lab and in the clinical space. Yeah, and then about the basic pediatric protocol. Yeah, so remember, they're sort of like IMCI or very basic protocols for standard diagnosis. And in all these cases, you've seen we've given okay, these are additional things that you should consider. But where it's a straightforward acute watery diarrhea, you would say this is viral. Maybe those are not the patients we're talking about. So the protocols are correct, but should be taken in context. Yeah, if I'm using my protocols for immune-compromised patient or for a patient who is severely ill, critically ill, it wouldn't make sense. So it has to be always used in the right context, and that's why also the panels we're recommending should be used in the right patient, in the right time, the right test.
Any other questions? 1 million years ago, doing a blood sugar necessitated going to casualty, getting the blood to the lab and all that. Now we have these gadgets at home costing about 2,000 shillings. Same thing happened with COVID tests. When they came, they were costing a bomb. Now people are keeping these tests in their houses. We even have these limited panel tests which you can do, and it will cost you less than 1,000 shillings available in this market. So probably in many years' time, even this test will become maybe the first place where we send a patient, because it shortens the journey, and if the cost is acceptable and people have become used to them and how to interpret them, then things will get better. Any other question? So I would like to thank you all for your participation in this mid-morning to early afternoon presentations. And now I'll ask Dr. Sigei to come and invite you for the next step. Please clap for yourselves.
Yeah. Thank you very much, Dr. Oredo. So thank you for being patient with us. I know we are running over schedule, but we are going to try and catch up. We'll now go for lunch, and we'll request 45 minutes maximum. So let's be back by just before 3. The remaining session, we promise to find a way to do it within an hour or so. So by 4:15, we should be winding up. So in terms of lunch logistics, Edwin is at the back there. I think you have the vouchers. Or who has them now? Or Julius. So Julius will stand up so that everyone can see who Julius is. Can distribute them to you as you walk out. I think the lunch is on 3rd floor. Yeah, so you'll excuse the hotel. There's a lot of changes happening here, so a bit of logistical change from the usual lunch venue. So let me request that we try and keep the lunch short so that we can close the meeting early and allow you to continue the rest of the weekend. Unless there's any other burning announcement, you're invited for lunch. Thank you. Sorry? Before 3. 2:50 we will start to push people to come back, yeah. So we're trying to do 45 minutes, please. I think it's possible so that we are able to wind up. I hope that's acceptable with everyone. Thank you very much. So good afternoon. Welcome back. So good afternoon, everyone. Welcome back. Hope you had a good lunch, including those online. So we want to move to the final session of the day, and we've changed the program a little bit just to accommodate various issues. We'll start with the case discussions, and then the biometric presentation will be the last one. So at this point, I'd like to invite Dr. Francis Kigu back to the podium to kick us off with some cases on the GI panel. And this is supposed to be an interactive session, so I presume he will ask more questions and expect more of you in terms of discussion. So both online and in person, feel free to engage so that we stay awake, especially after that heavy lunch. So please join me in welcoming Dr. Kigu again.
Thank you, Dr. Sigei. So like Dr. Sigei has said, I think this is supposed to be more like a workshop forum. So it's supposed to be quite interactive. So I really hope that I'm be getting feedback from the audience as we go along and look at some of interesting cases that pertain to Biofire testing. Okay, so we can start with the first case. 7-month-old male infant taken to the pediatric casualty. The complaints were decreased appetite, irritability. The mom also complained that she had noted traces, just scanty traces, of blood in stool over the past 1 day. Okay? But there was no history of frank diarrhea, no history of fevers. On examination, the child was well nourished. Vital signs were unremarkable. Abdominal examination, there was no distension, it was non-tender, and there were no palpable masses. Okay. So a request was made for a full blood count that again was unremarkable. The CRP, just borderline elevation, nothing really to talk about, 6.2. And there was a request for stool microscopy and culture. So the microscopy definitely came out early, immediately. And it was unremarkable. And the culture that came out later was negative for pathogens. So what are the thoughts from the audience at this particular point? Or how would you, assuming you are the clinician, how would you want to proceed? I think I'll try and take the mandate of trying to keep people awake, so don't feel bad if I pick on you or I pick on your table. Any takers? Good.
The babies I treated must now be in university or somewhere beyond. But maybe from what we have seen so far, there does not appear to be danger signs, so to speak. So maybe just encourage rehydration. If there is pain medication, and see what happens.
Anybody else with another opinion? Okay. So this is a 7-month-old baby. So around that time, that's when you're talking about issues to do with weaning, okay? So the clinician thought could be a case of maybe food protein-induced proctolytis, because this is the way it presents. You know, it's a well baby. Sometimes they have a bit of blood in the stool, and they will usually not be sickly per se. So they were encouraged to maintain hydration, to do sort of like an elimination diet plan, try and figure out what they had introduced recently and probably eliminate it, and basically just monitor the baby at home and be on the lookout for danger sign, like Dr. Waweru has said. Okay. So 4 days later, they came back for review. And there were new complaints now because there was fever, there was diarrhea, and the diarrhea was described as being watery. On examination, the child was dehydrated, had a temperature of 38.5 degrees, and there was another request for a hemogram that revealed an elevated white cell count. Not too much, around 19.9, with the cutoff for that age is around 15. It was predominantly a neutrophilia, and there was a request for stool culture at that particular point. Okay? Again, I come back to the audience. Things have changed a bit. Do we want to change the approach? Do we want to expand the testing? Are we comfortable? Anyone? Even from the online audience? Okay. So at this point, there was also a request for a GI panel that detected Campylobacter jejuni. Okay. And what was instituted in terms of management was, of course, rehydration, because that is crucial. Was started on azithromycin. The fever subsided, and the diarrhea also gradually improved over the past 1 week, over the next 1 week. And of course, for such a baby, because you don't usually expect to see such a pathogen at that age, then the concern would be, how is the food being prepared at home with regards to this particular baby? So they were counseled on hygienic preparation of foodstuffs. And yeah, so that was a good outcome. The thing with Campylobacter, for example, is it's a relatively fastidious organism. So even in culture, you require certain stringent requirements. So sometimes it can be easily missed out. But in terms of management and response, you usually get it good response once you institute the right management. All right, so case number 2 is an 18-year-old female who was seen in the gastroenterology clinic. She had a bit of a chronic history, recurrent abdominal discomfort, diarrhea, and flatulence. Because of the chronicity of the symptoms, she had been managed for various things. And currently there was a concern that she probably had irritable bowel syndrome. But the management that had been instituted to try and manage the IBS seemed not to be working, and the symptoms seemed persistent. So she had been referred to the gastroenterology clinic for a review. She also indicated that she had had previous stool cultures that were reported as being negative for pathogen. In terms of pertinent medical history, she is on management for lupus. And in terms of medications, that's steroids and azathioprine. When she was examined, she was in fair general condition. Her vital signs were unremarkable, and the systemic examination was also pretty unremarkable. So full blood count was requested. She had a nomocytic anemia, just a mild nomocytic anemia. The CRP was mildly elevated, and there was a request for an abdominal ultrasound that reported non-specific features. There was just a bit of increased wall thickness in the duodenum and the colon, and this was reported as being patchy. Again, there was a request for stool microscopy, culture and sensitivity. Again, that was negative for pathogens. And at this particular point, she was booked for OGD and colonoscopy to try and explain her symptoms. So at the same setting, she also had a GI panel requested for that detected Giardia lamblia and probably saved her trip to the endoscopy suite because she didn't need to go for endoscopy. Okay. So she was started on treatment with metronidazole, 400 milligrams TDS for 1 week, and she was reviewed after 2 weeks, and she reported that she had had significant improvement. So her symptomatology was attributed to giardiasis. And the thing with giardiasis sometimes is there is the avenue of picking it up on stool microscopy, but microscopy has about 60 to 70% sensitivity. So for patients, sometimes that can be missed, especially maybe if the patient has been on certain antiprotozoal medications that sort of suppress the load that you're getting, or even based on the skill of the person who's reviewing the slide. I think Dr. Waweru seems to have some feedback that he wants to share, so it would be amiss.
Yeah, with these chronic patients and the fact that they have an autoimmune condition, I would still be worried about inflammatory bowel disease like ulcerative colitis, especially with those changes on the ultrasound. I would push for OGD colon.
Yeah, it's a pertinent feedback. I think maybe the thinking in this particular setup was you can initiate management in terms of giving the antiprotozoal and see if there's response and follow up and see. If there's a persistence in terms of symptomatology, yes, then the patient would warrant to have an OGD colonoscopy. And also remember, this is a patient who's on immunosuppressives. So that can also, worsen the kind of infections that she's having and can actually end up, this is a patient who can actually end up having giardiasis for a very long period of time. But I agree with you, this is a patient probably who needs follow-up and just to try and see maybe whether there is something else that is being missed. So this is the last case. 35-year-old female, acute onset of watery diarrhea, vomiting, abdominal pains, and she also reports of fevers and chills. Okay? And she reports that she just recently returned from a 1-week holiday in Watamu that was marred towards the end by the onset of these symptoms. Okay? Any thoughts? Or any clarifications? Any more history? So when she was seen, she was sick looking. She was slightly hypotensive. And there were a couple of tests that were requested for, including a full blood count. At this particular point, that full blood count, again, was unremarkable. And this is sometimes something that you see a lot with some of the gastrointestinal pathogens. CRP was mildly elevated at 17. The stool microscopy, on gross, it was noted to be watery. There were no pus cells. And at this particular point, there was also a request for a stool culture. There was a request for a rapid test, that's an antigen test for cholera, that was negative. Okay. Any thoughts from the audience? And it's not just because we are discussing about Biofire that the next test is going to be Biofire. It could be something else that we are missing, because we are trying to look at the patient holistically. We are trying to manage them within the ecosystem that we normally have within our hospitals. Okay. So there was request for a GI panel. Had Vibrio detected. Okay? But we can say this panel has two assays, so generally for Vibrio and for Vibrio cholera. So Vibrio cholera was not detected. Okay? This is more for lab professionals in the house. I would not want to mention your name, but this is a culture plate, okay? So normally for Vibrio, we have special media, okay? It's called thiosulfate, citrate, bile salt, sucrose. So this is the colony morphology. Now, usually for cholera, the colonies are yellowish, okay? So this is not yellow. This is greenish. So I don't know whether there is anyone from pathology, from lab medicine special, who would want to make a comment. Or maybe I'm just going to ambush one.
I think all I can say is that it's an unsucrose fermenter, and Vibrio cholera, as you have rightfully said, will be yellow because of sucrose fermentation.
So I think what seems to be the agreement is that yes, it's growing on this media, so it's likely to be a Vibrio species, and that concurs or tallies with what was what was detected in the Biofire, but it's not a cholera in terms of species. So this was subjected to identification on the Vitex system, and it came out as Vibrio parahemolyticus. And in terms of management, she was rehydration was instituted. She was put on doxycycline, and she made a brisk recovery. And the thing with parahemolyticus is that usually you find it in terms of contamination of seafoods, and probably her history to Watamu was what was suggestive, or that's why she likely picked up, because most probably there was consumption of shellfish or other marine foods. And that is the end of presentation. I hope the cases have tried to drive home some of the things that we have been discussing about testing using the GI panels from bioMérieux. Thank you very much.
Thank you very much, Dr. Kigu. I hope that was enlightening in terms of how to approach the patients when you're combining this test with other modalities for optimal evaluation. So next up we shall have Dr. Navid. Are you still coming with Dr. Awaweru this time, or you'll come alone this time? Yeah, so Dr. Navid will come in to share some cases on the pneumonia panel using the same approach. So let's keep it interactive. Let's ask questions. Let's debate these interesting cases. It's not yet there.
You can hear me? Okay, so this is our case. This is a case that Dr. Waweru and I worked on just the other day. And we called it Occam's razor, not all the time. This is the history. 70-year-old male, an ex-smoker, currently undergoing treatment for laryngeal cancer, undergoing radiochemotherapy, and is also on dexamethasone. He's HIV positive on ARVs, reports to be compliant on his therapy, and has had a past history of TB about 10 years ago. The patient is also known to have a tracheostomy and has had a 3-week history of productive cough, fevers, weight loss, and recently used levofloxacin for 7 days. Clearly he didn't get better because he came in septic shock with a blood pressure of 70/45, an elevated heart rate, and an SpO2 of 78% on room air. On examination, the patient was confused, had diffuse bilateral coarse crepitations. Preliminary investigations are as follows. The patient had a severe metabolic acidosis as well as a respiratory acidosis. A pH of 7.2, carbon dioxide of 56, bicarbonate of 18, and the patient is also hypoxemic with an O2 of 45. The blood count shows low hemoglobin levels, elevated white count, and low platelets. The CRP is 233. The procalcitonin was 16. Creatinine was 170. Sodium is elevated, so this probably sounds like a pre-renal AKI. Liver function's okay. The CT4 is 150 and the viral load is undetectable. So the next thing would be, what are the challenges in this patient, or how would you approach, for example, a patient like this with septic shock? And the challenges we identified were, one, the problem is multiple sources of immune suppression. He's a cancer patient. This is a patient who's been on steroids, recent chemoradiotherapy, and he's got ARVs. The patient is also clinically unstable. It does mean you have to work a lot faster. Your choice of empiric antibiotics changes because this is an ICU level patient, and the differential here tends to be a bit broad. So if I go back to the history, at least here, we say that we've got a 70-year-old male in septic shock. Your examination suggests a lower respiratory tract infection. The patient has a tracheostomy, and you start to wonder what kind of infection you're dealing with. For example, this can be bacterial pneumonia, very likely. The patient also has a tracheostomy. You get retained mucus, impaired clearance of secretions. It's a very likely diagnosis. But we can't forget that these used antibiotics, it didn't get better. Are you dealing with a resistant organism? The next thing is that, are you dealing with other atypical germs? For example, TB is an HIV patient. Again, chronic history. Number 2, PCP. This is a patient with a low CD4 count and in respiratory failure. And number 4 is other bugs like fungus or other germs like nocardia and other things that affect immune compromised people. So this is a CT scan, and I'm going to play that so that you can see the CT. Okay. Good. So I'm going to play it again so that you can get a good look. And if you look at the CT scan, you're going to see lots of diffuse reticulonodular infiltrates in both lungs. It looks like there's some collapsed segment in the apical segment of the right upper lobe, and it looks like there's some small cavities. The differential here tends to be broad because, again, you start thinking, is there bacterial or atypical bugs? Is this fungus like aspergillosis? Is this something like TB? It also looks like there's some ground glass infiltrates. Again, this could be PCP or a mixture of all the above. Okay, so what next? So the patient was started on IV piperacillin tazobactam as the cultures were weighted. Clinical status is a HDU patient, 8 liters of oxygen on norepinephrine 20 mics per minute. We get a tracheal aspirate culture, no growth. Tracheal aspirate for TB is negative. Blood culture, no growth. In 48 hours, the patient has not improved. Patient is still febrile. He's on 10 liters of oxygen. Now what do you do next? So a tracheal aspirate was sent for a biofire, and we got Klebsiella pneumonia. So yes, finally we got something on, we got some organism that's responsible. And we did get some resistance on this, so it's ESBL, OXA48, and NMD. Again, you've got carbapenem-resistant Klebsiella, and the next question is, what antibiotic are you going to put this on? And this is where I think it's supposed to be an interactive session, so I'll pass the microphone on. Any takes, antibiotic choices for this patient?
Maybe before I answer that, by any chance, was there a request for culture from the tracheoaspirate? Because sometimes it's good when you correlate the two.
Yeah, so tracheal aspirate had no growth. Any other ideas, antibiotic choices? We can pass the mic around. Dr. Waweru, any ideas on this one?
I was there. Yeah, we scratched our heads. And because our patient was doing very poorly, we started on ceftazidime avobactam. But we decided to do other things, as will be seen.
Okay, so patient was started on antibiotics. Therapy seems appropriate, at least you know it's resistant. So 72 hours later, again, you've got slight improvement. Patient's a little better, down to 8 liters of oxygen. CRP is down from 233 to 211, so not much. Procal is down from 16 to 14, again, not much. By now, 3 days in, you would expect at least a modest response to the antibiotics, and the clinical response should follow. Progress, in our opinion, felt slow. The patient is febrile, and now we ask ourselves, are we missing something here? And this is where now the concept of a polymicrobial infection comes in. Remember that the culture grew nothing. The tracheal aspirate TB PCR is negative. You've done the biofire. It's already given you something, but we're not getting better. Any ideas on what to do next? Okay, all clear? Yeah. Okay, you can ask, yeah.
So I think Dr. Cyrus is asking the chat if a galactomannan test can be considered in view of the fact that cultures may take a while.
That's an excellent idea. Galactomannan is probably the next step. So here, no, it wasn't done. The turnaround time for a galactomannan is almost a week, but that's a good idea. Anything else? Any other ideas here?
Mine is a comment based on the presentation in the morning. Maybe the considerations could be some of the things that Biofire itself is not testing. So I think there was mention of the likes of PCP, and this is the context of somebody with multiple immunosuppression, so maybe those will be some of the considerations.
Yeah, you're absolutely right. At least that's what we think, and we thought along the same lines, that are we missing something that a very extended Biofire panel is not picking? And that narrows the differential significantly, because what it doesn't test for is TB, PCP, fungus, Acinetobacter, if I'm not mistaken, some of these other bacteria. So yeah, we need to be looking in that direction. In an immune suppressed patient with this kind of thing, the next step is probably to get better sampling, because the tracheal aspirate didn't give us an answer. If we compare tracheal aspirates and you study them for PCP, the sensitivity is not that good. You can do a PCP test on sputum, it's like 30% sensitive. You can do it on a tracheal aspirate, it's between 30 and 50. In such a patient, you need something with a very high yield. And yes, we were looking for PCP and we were looking for fungus in this case. This is what we found. And this is a video. We did a bronchoscopy. We decided to get the best possible sample, and this is what was sitting inside the airway. So what you're seeing as you watch the video, so this is the right upper lobe segmental bronchus. We think this is probably the anterior segmental bronchus, and it's completely occluded by some foreign-looking material. What you're seeing going in, that's a cryoprobe. And what we do is, we think that's an endobronchial aspergilloma. That's generally what it looks like. It can occlude the bronchus, and you'll see when the probe goes in, lots of pus starts to come out, because the lumen is completely occluded and there's pus behind it. And we basically pulled it out with that. And there you go, the aspergilloma is out. Or rather, it's taken out piecemeal, that's a portion of it. But we then inspected the airway and took lots of biopsies as well from the mucosa. And what we got after this was a histology positive for aspergillus. And what we had here was actually a case of invasive aspergillosis, concomitant with the bacterial infection as well. PCP on this patient particularly, I think, was negative, but the patient was started on IV liposomal amphotericin B as well. I think we chose ampho B because there was a history of this patient having used voriconazole recently for something else, and we decided, and the patient was clinically unstable, so we went with ampho B. And we actually had a good clinical response in 48 hours, and eventually the patient completed the antibiotics and the antifungals. So take-home messages, I think, here is that, one, if you have a patient with immune suppression, you need to think really broadly and investigate outside the box. Don't forget about atypical bugs. Don't forget about fungus. Don't forget about TB, PCP, and other bacteria. The Biofire is good, but it doesn't test everything. And in a patient who has immune suppression, you really need to think about everything. Trust your judgment when a patient doesn't improve as well as you think they should. And this is because you might be missing something in this picture. And here we had multiple organisms. So we only got half the diagnosis the first time, had to investigate a little bit deeper, and then get the rest of the diagnosis. That brings me to the end of the case. And if there's any questions from the audience. Then I'll hand over Any questions?
So, thank you so much, Dr. Navid. I think we can give him another round of applause. Really appreciate that. So, we're coming towards the last presentation, and this afternoon we've been joined by Dr. Janet Maranga, who's a clinical pathologist at Gertrude's Children's Hospital here in Nairobi. She's currently in charge of the molecular and microbiology sections, and she has a lot of publications and conference presentations. She's very passionate about antimicrobial stewardship, infection control, and medicine and therapeutics. And she's also involved in continuous education of hospital staff and training of students at the Gertrude's Institute of Child Health and Research. So I'd like to welcome her so that she can take us through some interesting cases that they have encountered at the Gertrude's Children's Hospital. Karibu, Doc. Let's clap for her, Shikam.
Thank you, Sige. So today I will discuss two cases using the respiratory panel and the meningoencephalitis panel. So we'll start with the respiratory panel. So this is the current RP 2.1 plus panel. As you can see, it has various viruses and bacteria. And these bacteria are the ones we cannot isolate on routine culture in the lab. So it's quite good for patients with this type of bacterial infections. And I think the panel has evolved over the years. Initially, the RP2 panel did not have SARS or MERS. Then they included MERS in the RP2 plus. Then RP 2.1 had SARS but did not have MERS. Then RP 2.1 plus now has both. So I can say at Gertrude's we've gotten positives of all these viruses and bacteria apart from MERS for obvious reasons. Yes. So for our respiratory case, we have an 8-month-old male who presented with a 4-day history of dry cough, labored breathing, vomiting, diarrhea, that the mother said was she could not quantify how many episodes of diarrhea he had, and fever. He also had 1-day history of generalized tonic-clonic convulsions, that was several as well. So when the symptoms began, that is just the cough and the vomiting and diarrhea, he wasn't too bad. He went to an outpatient facility and was diagnosed with GE due to teething and a chest infection, given an unknown medication. But the mother took the baby back on day 4 because he had become really ill, was having respiratory distress, and now the convulsions had begun. So the child was given IV fluids, given a start dose of ceftriaxone to cover for meningitis, and started on oxygen and referred to Gertrude's. So when he came on examination, in terms of the respiratory system, his breathing was irregular, the respiratory rate up to 60, had chest wall indrawing, reduced air entry, and rhonchi and coarse crackles were heard, and he was saturating at 91% on room air. Circulatory, his pulse rate was 163 with cool extremities. Capillary refill rate was at 5 seconds. He also had sunken eyes and was pale with hypertension. However, he was passing urine. In terms of disability, on the AVPU scale, he was alert. His pupils were bilaterally equal and reacted to light, and he had increased muscle tone, and seizures were observed at outpatient. His RBS was normal. On exposure, there was no bleeding, no soiled clothing. His temperature had a slight fever, but they noticed his skin was dry with scaly white patches on the face. So this child has like a lot of things going on. In addition, we always do ENT exams for children. So the right tympanic membrane was found to be bulging and red. The eczema was just part on the patches on the skin. So at this point, with all these things going on with the child, what are your diagnoses? Several things going on. It's not just one diagnosis. Anyone? So he has diarrhea, vomiting, seizures, fever. Yeah.
Right. Is it sufficient to diagnose sepsis?
That's a good, yes. But from what?
I think it's bacterial, but I really can't tell with the description so far. And the focus may be respiratory. So probably a gram-negative agent.
Okay, thank you. So he was admitted in ICU. So the working diagnosis was meningoencephalitis, severe pneumonia, acute gastroenteritis with severe dehydration, acute otitis media, and seborrheic dermatitis. But the reason he was taken to ICU was because of the respiratory distress and the convulsions. So by the time he was being admitted, his GCS had dropped to 10/15. At a VPU scale, he was now at P, which is he was only reacting to pain. And he was noticed to have continued generalized convulsions despite multiple anticonvulsants during his stay in ICU. So a decision was made to intubate him. And he was still having respiratory distress still at this time. So some of the labs that were done and other investigations, his chest X-ray was found to have bilateral ground glass opacities. This was done before he deteriorated. His procalcitonin was quite elevated at 39.3. He had deranged electrolytes, so sodium, potassium chloride, magnesium, calcium are all low. He also had prolonged PT and APTT. So at that point, we were thinking, does this patient going into a DIC because of sepsis? Malaria antigen and blood slide were negative. Blood culture, after 5 days incubation, no growth was obtained. Because of the convulsions, EEG was done, which was normal. Video telemetry was also done, which was normal. And RES Biofire was done, which found influenza A, but no subtype was detected. Another sample was taken a few days later, still gave the same result of no subtype detected. So interesting for this patient, they thought he was too unstable to do a lumbar puncture, so CSF culture and Biofire was not done. And for some reason, stool was also not submitted for either Biofire or culture. I'm not too sure why. But this patient was actually a candidate, I think, for all the 3 Biofire panels. So I don't know if anyone here with experience with the respiratory Biofire have ever gotten such a result of no subtype detected of influenza A. Okay, likely not. So for us, we get it. We've gotten it quite a number of times. So in terms of influenza A, it's an RNA virus, and how it is named, the different subtypes, is based on the hemagglutinin and neuraminidase proteins on the surface of the virion. So it'll be H1 something, N1 something, or H2, N2, like that. And the most common strains that affect humans are H1, H1 2009, which is the most dominant strain now since 2010, and H3, which are the ones now the respiratory Biofire detects. So when it comes to equivocal, you can get equivocal or no subtype detected results for influenza A. And I'll explain why. So when it comes to how the assay works, it detects 5 targets on influenza A. 2 targets are called the flupan-1 and flupan-2. This ones just tell you whether it's influenza A or not. Then once this is detected, then there are also subtyping assays which tell you which type of influenza A is it. Is it H1 or H1 2009 or H3? So these 5 assays are usually used in interpretation of the results by the Biofire software. So this is just a table that shows how the results are generated. So the second column shows you the flu pan assay, which tells you whether it's influenza A or not. Then the other three are detect subtyping assays for H1, H1 2009, and H3. So for you to get a positive result, at least 2 of these 5 assays should be positive. So if we look at the third row, for instance, where influenza A H1 is detected, the one or more of the flu pan assays was detected together with H1. The same, if H3 is detected, one or two of the flu pan assays is detected together with the H3 subtyping assay. However, you can get now equivocal or no subtype detected results when one of the assays is positive rather than 2. So you can get influenza A, and you can also get a combination, like more than 2 of the assays are positive. You can get a flu pan positive and H1 and H3 positive. So it's recommended to retest this sample to make sure it's actually a dual infection of different influenza viruses, which is really rare, but I guess it's possible. So when you get a no subtype detected result, it means that influenza A was detected. So the flu pan A assay, both of them were positive. However, when it came to the subtyping assays, they were all not detected. So at this point, there are certain procedures you're supposed to follow to confirm the subtype. Then an equivocal result would be where you have the H1 2009, H3 subtyping assays are positive, detected. However, the flu pan assay, which tells you whether it's influenza A or not, is negative. So when you get a no subtype detected result, what should you do? And what causes this? So it could be that the virus in the sample is at a low titer, and so the subtyping assay could not be completed. Or it could be the patient has a novel influenza virus, not the H1 2009, and H3 that are commonly found in humans. So if this is found, a retest should be done to confirm. So if this retest is done and now you're able to subtype, it tells you it's influenza AH1, then you should retest a third time to ensure the accuracy. So if this third repeat tells you it's influenza AH1, you can go, okay, yeah, fine, this is H1, that's a result you will release. However, if on retest, it still tells you no subtype detected, before you think it's a new influenza virus, A virus strain, then there's some controls you should do in the lab to make sure that your system is working functionally, properly, optimally, your Biofire equipment or your pouches. So here you need to use negative control material, so you can use either saline or transport media that is, not used, to make sure that there's no contamination in the system, and also known positive controls. So if you have access to known H1 2009, and H3, all 3 should be done to make sure that your subtyping assay is actually working properly. So if you do these positive controls and negative controls and they pass, then perhaps you can think, okay, it might be a new influenza virus strain. So at this point, the sample should be referred to a referral lab for them to do sequencing to try and find out what kind of strain it is. So you can see it's quite an expensive effort. If you get such a sample, you have to repeat it like up to 3 times. Then if you still doesn't get a subtype, you have to do 4 controls. It's quite expensive, and who's going to pay for this? Really, you can't expect the patient to pay for this. So it's been a bit of a challenge for us because we don't get to that 5th level of having to do controls because of the cost. But that's how you should actually do it. So when you get an equivocal influenza virus A result, again, it could be due to low titers of the virus in the sample. So it could not be detected in the pan-A assay. This can happen, like I think Dr. Kigu mentioned in the morning, how the sample is collected, the swab. If you don't swab hard enough, you might not get enough epithelial cells that have infected virus to be able to run the assay. So, but it could also indicate that it's a different type of influenza A strain. So at this point, you can just repeat to see whether it will give you the same results or not. So for equivocal results, you don't have to go through the whole process of repeating controls and everything. You can just, if repeat gives you equivocal, report it as equivocal. But I'm sure you'll get calls from the doctors asking, okay, what does this mean? What should I do? So this also happens with MERS. So influenza A and MERS can have the same issues in terms of getting equivocal results. We'll go to the next case, which is a patient who got a GA panel. Sorry, this should be ME. So AMM is a 6-month-old female who presented with vomiting and bulging fontanelles for a few hours. So the mother reported that she had gone to a facility, was given vitamin A at around midday. Then 4 hours later, the mom noticed, this fontanelle is bulging. So she returned back to that clinic and they told her, that bulging it's most likely a side effect of vitamin A. I don't know how true that is, but anyway, she went back home. And at around 10 p.m. same day, now the child became sick, started vomiting suddenly, non-projectile, had several episodes, was not retaining anything. She was really crying and restless. However, she had no fever, no convulsions, no diarrhea, no other issues. So when she presented at Gertrude's outpatient, she had normal neurologic exam. She had no stiff neck, no photophobia. Though I guess photophobia, to elicit that in a child this young is difficult. Anyway, she had no lateralizing signs, no posturing, no increased tone. Really, everything was normal. Then stool was taken for antigen for adenovirus, norovirus, rotavirus, which were negative. Then stool microscopy was also normal. Then culture, which came out a few days later, had no growth obtained, or rather no pathogen isolated. She had normal labs, UCs, PCT, CRP, but because of that history of having a bulging fontanelle and vomiting, she was started on ceftriaxone. So for this patient, would you do a lumbar puncture? She has hours history of a bulging fontanelle and vomiting. No fever, no neurological symptoms. No imaging yet.
Right, I think as long as there is no evidence of raised intracranial pressure, they should still do an LP, right? And I think an LP should be done.
Okay, yes. So an LP was done on the same day of admission. So in terms of these were the results initially on the CSF studies. So the CSF was clear, it was not turbid. The glucose was normal. My WBC count was quite low at 0.01, and most of them were mononuclear cells. However, the total protein was on the lower side. Gram stain was negative, Zn stain negative, India ink, no cryptococcus was seen. So based on these findings of a low protein, normal glucose, and low WBC count, but mostly mononuclear cells, a viral meningitis was suspected. So the same sample, the meningoencephalitis panel, was done. This is how the results appear from the Biofire equipment. You have the patient data and when it was done and what time it was completed. Then of note, you can see the controls at the top left corner, top right corner. It passed because it's possible to get invalid results, as was mentioned in the morning, where the controls within the pouch don't work. So the results, the run does not proceed to completion. So what was detected was strep pneumo and human herpes virus 6. So the next day when she was reviewed by the infectious disease specialist, he noted that she had not vomited further and the fontanelle had gone down. She was still afebrile, and based on the ME results that came out, the ceftriaxone was stopped, and the pediatrician decided to just discharge her the same day on oral valganciclovir. And on follow-up, up to 3 weeks after discharge, she had no issues. And now after discharge is when CSF culture results were ready and no growth was obtained. So that strep pneumo was not isolated. So I don't know if maybe some would think that this pediatrician was very brave to discharge her on the second day, just based on the ME results and the CSF biochemistry. But I think from his experience, he's seen quite a lot of this. He thought this was not a bacterial meningitis because it was, very sudden onset, no fever, and she just had vomiting and the bulging of the fontanelle, which went down anyway on the next day. So, even maybe the treatment of the HHV6 might not have also been indicated. So, I think Dr. Adil had mentioned earlier about finding herpes 6 in CSF. So herpes 6, just like CMV, can establish latent infections, which can be reactivated if someone is immunocompromised. But most people will have it, but will have no symptoms. And it can also be vertically transmitted from in the germ cells. If a man or woman has it, it will be passed on to their offspring, because it's chromosomally integrated in their germ cells. So a child can actually be born with chromosomally integrated HHV6. However, for most patients, as much as a lot of people will have HHV6, they will be asymptomatic. And even if it reactivates, they will still remain asymptomatic. And even after an acute infection, you might still be able to find that herpes 6 in CSF. So given the prevalence of having latent infections or asymptomatic reactivated HHV6, positive HHV6s in CSF should be carefully interpreted in terms of the patient's presentation and other lab tests. So there has to be something else to support a diagnosis of meningitis or encephalitis in a patient with a positive HHV6 in PCR. So this is, a challenge across the world. Neurologists and pediatricians, some will treat it, some will not, based on, how the patient is presenting. And, some will give treatment for 3 weeks, others for 1 week. So it's really not standard from what I've been seeing in people's practice. So I think this child was treated as a case of encephalitis, meningitis caused by HSV6 because of the vomiting and the bulging fontanelles. And for the strep pneumo in CSF, this patient was not treated. It was considered to be possibly a contaminant because the patient didn't have features of bacterial meningitis. So this can actually happen. You can isolate strep pneumo in CSF in a patient who does not have bacterial meningitis from it, because strep pneumo colonizes the upper respiratory tract. So if somehow the CSF was contaminated during the sample collection, maybe the person was not wearing a mask doing the LP, coughed into the sample, we don't know. Or during the handling of the sample, it's possible to introduce a strep pneumo in it, and PCR being sensitive, it'll still pick it up. And also of note is that those who are carrying strep pneumo and H influenza in their respiratory tracts, or those who have cold sores or an active cold sore who have now HSV1 will shed this bacteria and virus into their CSF, not because they have meningitis, but it just spills into the CSF, so it will be detected on PCR. So, as was mentioned earlier, it's very important to treat the patient rather than the results, because this is a patient who might have stayed in the ward for more than a week if they had been treated as a case of strep pneumomeningitis. So we'll end it there.
Thank you very much, Doc. So are there any other questions, either to Dr. Maranga or even to Dr. Kiigu, Dr. Navid? Any final questions? I know there were some comments in the chat, which I can try and read a few of them. Where's the chat? Yeah, so I think on the chat, no, it's fine, yeah. One of the comments that has come in from Dr. Madeka, I think this was for Dr. Navid's case. With Biofire, some of the detections, because it's a highly sensitive test, they might include colonizations which don't necessarily represent pathogens. And that's something we normally talk about. So in a patient with multiple contacts with the healthcare system due to comorbidities, the CLEB may have been an incidental finding. Similarly, detection of some of the resistant genes may not mean they're expressed, which is something we also comment. It's genotypic expression, not phenotypic, but it's really useful in formulating a decision or a direction. Yeah, I think that's one of the comments I saw. I don't know if there's any other from the audience. I know it's the end of a very long day, so people are a bit tired, but yes, Dr. Oredo, go ahead.
I have two questions to Dr. Maranga. Number one, what happened to the first child who had multiple things?
So he remained intubated for a few days, and he was given multiple anticonvulsants just to prevent the convulsions from occurring, antibiotics as well. Eventually he recovered. I think after a few days he was extubated, and then after three weeks he was discharged to the ward. And so the plan was actually to do an MRI to find out why, because now that after that episode, the convulsions and being on respiratory support, they thought he had hypoxic brain injury because he started having some other neurological signs. So an MRI was planned. So it was done before he was discharged, but I couldn't get the results. But he actually did quite well.
And the second question is, I saw you following the influenza times 2, times 3, times 4. Does it matter?
So it matters in terms of just, I think, epidemiology. Treatment would be the same. Yeah, so it's just for epidemiology to inform us whether there are new strains in circulation, which would inform now development of a new vaccine. Yeah.
Thank you.
Thank you very much. Any final questions from the room? Let me also check online. There's a question on cost that had been put earlier. We'll park that to the end of the Biomary presentation. So I see no other questions in the room and also online. So at this point, I'd like to invite my colleague, my colleagues actually, Edwin and Kamau, so that we can finalize the primary presentation. I think Edwin will be starting, and we hope to take not more than 15-20 minutes to give you our perspective on this solution, some new highlights as we close the day. So at this point, Edwin, you can come over and start the presentation.
So thanks, Dr. Sige. So I'll also try to be very brief. I know it's been a long day. Thanks. So for me, I'll just take you through from a company perspective what we do and what is next. And be assured we'll use even less than the 15 minutes. So Biomiru is a French company. Sorry for that. Biomiru is a French company, and our pillars are based on three pillars. So one is the immunology. Then we have microbiology, and also we have molecular biology. So immunology, most of the time you know about the thyroids, the tumor markers, so we talk about the VIDAS and a wide range of testing. When we talk about microbiology, you know it's one of our strongest pillars. Talk about Vitek, Bactalat, manual microbiology. And then molecular, we have other solutions for singleplex, but in this case, now we're focusing here and we're talking about the Biofire, which falls under multiplex, but under molecular biology. But we also have other solutions for molecular biology. So when you're talking about syndromic approach, I didn't want to dwell so much on this. And if you look at my presentation, the advantage and the disadvantage. So basically, in summary, you're saying, if you're doing a syndromic approach, you do that informed therapy. Otherwise, if you, especially for the cases that are a bit complicated, as the doctors have presented, you could be doing an informed guess, yeah? And I wouldn't want to dwell so much on that. Here already, again, I wouldn't want to repeat, Dr. Kiig already discussed about the syndromic approach when you're doing the traditional testing. For this case, if you're using a CSF as an example, you could have one sample, multiple tests. You have the sugars, proteins, microscopy done from different sections. And you'll have, at the end of the day, you'll have different reports. Others maybe could wait 2-3 days, especially for culture. And if it's a patient who has been admitted, again, that will impact on the time of the patient maybe in the ward as you wait for the final report. With the syndromic approach, you have one sample, one comprehensive test within 1 hour, sample to result. So maybe if you add maybe the collection and so on, it could be up to 2 hours probably. You have one comprehensive report, and this could significantly have an impact on the patient stay in the hospital. In summary with that, we say it's fast because you only need 2 minutes of your hands-on. Everything is room temperature. Get the sample, load it in 2 minutes, walk away, come back in 45 minutes and pick the report, or 45 to 1 hour. It's easy because you can do it anytime, anywhere, within any size of the laboratory. So you don't need to have to be a research institution or those complicated normal molecular labs where you need an extraction room, you need to put on lab coats. When you move to the next room, you have to change the lab coats, pipetting, all those. So you don't need to do all that. And it's very comprehensive, as you can see. For the kit, it all comes with everything in it. And so just want to quickly show you for the especially the scientists and technologists in the room and online, how it works. So this is how the Biofire looks like. So you can upgrade from one module up to 12 of them, and you can work, if you're doing 2, you can do up to 58 samples in a 24-hour lab, and you can go way up to 351. So initially we're doing the 2.1, so this is what we call the 2.0, but we are now supporting it, but we are no longer selling it. So we'll be phasing it out by 2029. So currently we are promoting this, and if you could see outside, we are launching another one very soon. So the 1 hour which you're talking about could be now 15 minutes. But same technology, it's only that now an advancement. So again, it could do it anytime, any technology, so long as it's trained, any shift, any size of the institution. And this is just a quick video on how it works. So this is the pouch. This is the pouch and this is a block. So for preparation, you just need the pouch, you load it, you put the buffer, then of course you'll need the sample. So this process here is what you're saying takes only 2 minutes. So this is a sample being loaded, of course. You mix it, you swirl, you don't shake because of genetic material, 3 times. Then you dispense within the pouch. And your sample will be ready to load. Then the next step is now you load it into the equipment. So this is the touch, so depending on what you're loading. This is the cartridge, how it looks like. So the clock starts counting, so all your reaction happens within the pouch. Here we have 102 wells, so that tells you for every parameter, we do it in triplicate. So you cannot avoid to miss the target. So if out of the 3, 2 of them are negative or non-reactive, then that report becomes invalid. Now the good thing, every sample is run with a control as a surety. In the event of a control failure, we always reimburse back that kit. So that's the level which we say it's sensitive and specific also. So this is the process on how it works. I wouldn't want to take you so much into detail, so I'll just quickly forward. But basically, up to that point, you'll have done the step 1, where it's, you analyze the multiple targets, and then step 2, it will do the primer aligning with the targeted organism, and now you will see it will detect in triplicate out of the 102 wells. So this will be stage 2 PCR, where it's now doing like a singleplex within the target multiples. And in stage 2, you only detect only the target organisms that have been identified in stage 1. Then, of course, the instrument will do the analytics, and you'll be able to see the melting curves here, depending on how much target it has been identified. This is the kind of report you'll have. So depending on which target, which panel, if it's a new panels that have the genetic material, the resistant genes, you'll have 2-page report. If the respiratory, GI, and MU, you'll have a 1-page report. So for pneumonia, joint infection, and blood culture identification, you'll have a 2-page report, one with the resistant markers and the other one with what was detected. And quickly, these are the panels. I know we're dwelling so much on respiratory, pneumonia, and GI and meningitis. But just to show you the difference, the respiratory has more of the viruses, 19 targets, and 4 bacteria. Most of them are typical bacteria. Then the BCID has 43. And you see the good thing it has 10 antimicrobial resistant genes. Out of the 26, these are both gram-negatives and gram-positives, and 7 yeast. Then you have the GI, the gastrointestinal panel with 22 targets, and the meningoencephalitis, which has already been discussed, 14 targets. So this panel is being upgraded. It should be having more than 14, which is also, we should be launching in the, I think, 3rd quarter of this year. Then the pneumonia panel, so you can see, maybe you can ask the difference between the pneumonia and the respiratory. So for pneumonia, we have more of the bacteria than the rest and less of the viruses. So you can see for respiratory, it is more of the viruses and less of the bacteria. And here it's more of the typical bacteria. But for pneumonia, it has 18 targets, majority bacteria, and it's semi-quantitative. And for the question, like most of them being maybe colonizers, hence it's semi-quantitative. So you can be able to tell the cutoff value and know if it is pathogenic or maybe it could be just normal flora. Then currently the acting last born is a joint infection panel for synovial fluid with 39 targets, of course, with 8 antimicrobial resistant genes. So it's also available. Then quickly, let's look at the syndromic trends for those interested with research. This is like an epidemiological tool. So you can be able to see how the trends are going on. What are the peaks for maybe respiratory targets, if it's RSV, and so on. So you can be able to tell, and for research institution or for planning purposes, that this is what we're experiencing, or even for planning purposes, you can be able to know during the month of June or May, we normally experience a peak on something, and you can be able to use it for planning. Mostly research institutions and government, especially in Europe, we are using this to plan for, and also it can quickly tell you there's an outbreak, especially for things like Vibrio or a certain flu. So what next? So also, one of the advantage for the trend can also able to let you know what are the detection rates, because these are real-time information which you could be getting. Also detection of the counts, geographical trends, because like you can be able to tell within Nairobi, we're experiencing this peak without even really knowing which institution, but you can quickly know what are the trends and what is experienced currently. And also you can get the reports whether weekly, daily, monthly, depending on how you'd want to get. I think, I don't know if my colleague would want to take this through, or because of time, maybe I can. The BCID, Blood Culture Identification Panel, Joint Infection Panel, which are currently, like the BCID, we're already like doing validation with Aga Khan, but it's now available. Joint Infection Panel is also now available. The fever panel, which we talked about, this one, is now available, but with some exclusion of some of the target organism here, because currently the ones that are here, 5 minutes now, it will be only 15 minutes. In fact, for clinician, as you speak with your patient, you run the sample and you have the report in 15 minutes. So it's called the Biofire Spotfire. Then, as I mentioned, we have an upgrade for the pneumonia panel coming up, the GI and also ME panel. Other panels still under R&D is the STI panel, which is also coming up. So apart from also like the Biofire, we also have other solutions, like the specific reveal, which is also part of MR, part of our solutions, and it's quite fast, yeah, and actionable, and also integrated within our solutions. And also our team is here, Julius, Ben, Kamau can also give more shade on this, especially for those who are interested. And I think at this point, I would like to invite Dr. Sigei to give us the clinical indication and the correlation between the lab and medical perspective. Thanks.
So thank you very much, Edwin, and I'll go through mine quite fast, because I believe we are very convinced, or at least better convinced than before we came, after the cases that were presented by our colleagues. So I'll really just give a super summary in the interest of time. So I'd want to actually focus on this slide, okay? So let's summarize the benefits. The first one is it's a rapid test, giving you results faster, enabling you to make decisions earlier or even faster. Yeah, I think that one we can all agree. It's accurate. One of the challenges we have with existing diagnostics sometimes is the accuracy. As you can see, we have sensitivities and specificities way above 95% across all the current panels. It's comprehensive, and this is something that I think we've appreciated with the cases. You know, you have a lot of co-infections, which sometimes occur, and also there are pathogens or organisms that we don't think about because we are limited. We are not able to do viral cultures, for example. Even the basic parasites like Giardia, sometimes the basic microscopy is a challenge, and so many other factors. So again, this comprehensive test enables you to pick multiple things at once. It helps you overcome diagnostic challenges, and the challenges have been highlighted in all the cases, I think. The fact that culture takes very long, the fact that other tests can actually be negative or none, they're not helping you to rule in or rule out. So it's enabling you to do that, particularly when you think of CSF, stool, it's quite useful. It also helps us reduce unnecessary procedures. Sometimes we, with our basic tests, we jump to maybe imaging that may not be indicated at that point, X-rays, CT scans, and so on. I think even one of the cases you're able to avoid a test that should not have happened in the patient. So, if you're getting a result comprehensively in a short time, you can actually rule out some of the other tests. Antimicrobial stewardship, and I think in the era of AMR being the other pandemic, and probably a pandemic that we sometimes ignore, it's something to think about. We're able to help patients use antimicrobials for the right duration and only for those who actually need it. Yeah, so that's something very important. Reducing length of stay. Some of the cases showed, people are able to discharge patients after 2 days. I think a lot of us, if we think about our typical healthcare system, when somebody is admitted in hospital, if you hear they're discharged after 2 days, you'd be sometimes even surprised, because you expect that the first 2 days, in fact, they're figuring out everything with insurance and all the various tests. But if you're able to do that within 2 days, that's actually quite remarkable. And lastly, I would say cost benefit or cost effective downstream. And I want to underline downstream, because upstream, it's very easy to look at the cost. And one of the questions that has been asked is about the cost. And the cost at the upstream level would look quite high. But if you look at some of the benefits that some patients have accrued, if you're discharging someone earlier, if you're giving less antibiotics, if you're going in the right direction faster, you probably will actually accrue some downstream cost benefits. And there's some data, even local data, we are trying to work on to showcase that as well. So we have a lot of publications from all over the world, and including here in Africa. We do have some research sites. You've had some of them present today, like MTRH, Kemri Kisumu, the team in Mombasa, and so on. So we do have this document called Selection of Publications. It summarizes all the publications, and it does so panel by panel. So feel free to reach out to us. We can share with you. It's quite a bulky document, so those who prefer soft, we can share. Of course, those who want hard, we'll see what to do about that. And I think lastly, if you do have a research proposal that you would like to engage in around Biofire or any of our portfolio, we do have a process for that at Biomerio. We actually have a portal where you can submit, but we normally request that you reach out to us in the medical affairs team for an initial conversation, and then we take it from there. So we're happy to continue supporting more data generation locally that will enable us to use our diagnostic tools to fit our setting as best as we can. And I think with that, I come to the end of our presentation. Thank you very much. If there are any questions to the Biomerio team, this is a point we can take them. And the team is here full house, so apart from myself, Edwin, of course we have Edward who gave the opening remarks. We have Kamau, marketing manager, Julius and Ben Reeve, and also Nicholas and Marianne, seated right opposite each other. So, I hope I didn't miss anyone, yes. So, any questions to Biomerio? I'll also start checking the chat as we wait for those in the room to ask any questions or any comments. Okay. So let me first take this one. How are samples prepared? For example, blood culture. It's from Joyce online. So I presume she's asking about the blood culture identification panel, BCID2 currently. So for BCID2, it's blood culture identification, meaning that you must take a sample for blood culture, incubate it, ideally in the automated systems, and once it flags positive, As you wait for the typical process that follows, which is the gram stain, subculture, and so on, you actually then identify it within an hour, up to 43 targets. So you just follow the same process like you would for blood culture, but once it flags positive, then you put the sample just like the way Edwin was explaining. The process is the same for all samples in terms of what happens at the level of the pouch. Any other question? Those in the room, I think, are tired. They want some tea before they can ask questions. As I wait for that, I think we have no other questions in the chat. Yes. Any questions? Comments? Okay, so there was a question on cost, and I'd like to put one of my colleagues on the spot a little bit to just explain how we are planning, what we are doing around pricing, what we're doing around access. So if you don't mind, Edward, you could grab the mic and just make a comment on that. I think the mic is close by.
So thank you, Doc. I think the first thing that we are doing is having a few discussions with our business partners, number one. And in that perspective, in a bid to ensure that we have some level of management from the pricing perspective, we've put in a second distributor to support us, and they're well represented here. And we will see that cost slowly going down. Internally, as an organization, we've also been evaluating many other route to market models that will eventually see us get to the level of pricing that we want to. We are also working with insurance companies very closely. On Thursday, we had a meeting here, a payer provider meeting, and some of the doctors who've spoken today, Dr. Kigu, Dr. Maranga, were with us. And we got some very good sort of feedback from the insurance companies. And one of the feedbacks that really came in is they never understood Biofire very well. And with this continuous education, then you are seeing them opening up to the reimbursement, which was one of the cases where then if insurance are not reimbursing and people can't afford buying out of pocket, or they have to pay out of pocket and it's very expensive. So in the interim, that sorts out some of the hurdles that we've been seeing, and we are continuing the engagement. We agreed on formation of a working group whereby the insurance companies, the service providers, ourselves, and our distributors will have a caucus where then we discuss how do we come up with an access program for Biofire to ensure that it's not only the few privileged people who can get it, but we can drive it across the spectrum even to public hospitals, so that the likes of Dr. Walong can be able to enjoy the services of Biofire. So it's work in progress, and we are hoping within this year and next year, and next year we'll have seen some significant progress. And maybe very important to also point out the health economic studies that are being led by Dr. Sigei with the various institutions to really demonstrate not only to the people in the country, but even to the organization, that is Biomirio, on what we need to do to really get to the right price point. Thank you.
Thank you, Edward. Any further questions from the room or comments? Okay. So also online, I don't see anything further for now. And I think because we've stretched it a bit, I think at this point, I'd like to invite my colleague Kamau to give some closing remarks vote of thanks and close the meeting, basically. Karibu.
Good afternoon, everyone. Good afternoon, everyone. Yeah, thank you very much for making time to be with us on this beautiful Saturday. I believe it's not easy to actually spare time on a Saturday like today. And I want to request my colleagues at Biofire, if you could stand for a minute, wherever you are. Thank you. Those are my colleagues at Biofire, and I will request them to appreciate the speakers today. A round of applause for our speakers. Yeah, well done, well executed, beautiful insights, and a lot to actually take home. Yeah, please sit. Of course, let's take the engagement further. We want to see more and better collaborations. I don't know how this, on whether to drink or to buy airtime. That's the MBA 101. So Dr. Walong, some serious competition coming from the physicians' quotas that you not imagined before. Let's appreciate all joining us virtually. I mean, it's not easy. And also, as we wrap up, this is important to share. Ask, are you guys persuaded, convinced? Now is the time. Yeah, so thank you. That's our distributor from ScienceScope, and maybe you could just say your name.
My name is Isabel Mwangi, and I'm from ScienceScope, and we are the money people. So in case you need any placement and to place any orders, we are ready for you. Thank you.
Thank you very much, and let's appreciate it. Thank you. Yes, a very special guest as well, Mr. Mushiri. Maybe you could just stand for people to also appreciate that you came in. Mr. Mushiri is from industry, looking more into the Tanzania market, and he wanted to learn a thing or two today.
Hi, I've not been for one of these things in forever. I was a banker for many years before I went into business, and I think the last time I attended such a forum was in 2009. So I really like their products, and I think there's a lot of good market for them in the region. Thank you.
Thank you. Big challenge to all of us. In the healthcare space, it's been infiltrated by bankers, so you guys better look out. So now, as we wrap up this beautiful event, I would like to wish you journey mercies as you go back home. To those of us who are fasting, I think Dr. Navid, Ramadan Karim, and all the best. And I also want to invite Kano Mutembule to close with a word of prayer. Sorry? Oh, yeah, county 048. Yeah, those who don't know that, you can engage after this.
Good afternoon. It's evening. We are enclosed. We think it is afternoon. Good evening. Thank you very much for coming. Thank you, Biofire. We really appreciate your effort to bring this knowledge to the clinicians. And we really appreciate you go out of your way even to do this. We don't take it for granted. Now that our space has been hijacked by bankers, it is still okay. We are more than convinced, and we know that we are only limited subject to money. And we are now happy that at least you have engaged the insurances, and this is a bright future for patients. And for a short stay in the hospital and having a healthy nation. Praise the Lord. I want to close with a word of prayer so that we can go. Let us close our eyes and pray. Father, we thank you. Thank you once again for this opportunity. Jehovah, we don't take it for granted, but Father, it has taken your hand, Father. Thank you, Father, since morning. Father, we came here, Father, we've been impacted, Lord, with more knowledge. We have learned a lot, Father, Lord. We have seen, Lord, that there is hope, oh God. And we pray, Father, Lord, that Jehovah, as clinicians, oh God, you're going to help us, Father, and bless the works of our hands. And Father, Lord, you're going, Father, Lord, to open doors, Father, that Jehovah, we may bring this service, Father, to humanity, Lord, in a cost, Father, Lord, that will be affordable to all of us, Father. And for the future of this nation and even Africa and the world, Father, Jehovah, bless us, Father, Lord, and impact us, Lord, with more knowledge, even as technology continues, Father, Lord, to increase. Jehovah, we look upon you, Father, for more grace, O God, which is sufficient. Father, as we disperse, Father, we shall not forget your goodness, O God, because it supersedes, Lord, the opposite, O God. Go with us, Father. Cover our vehicles, Lord, with the precious blood of our Lord Jesus Christ, O God. Bless Biofire, Lord, and all the other companies, Lord, that are there, Lord, to work for your people, O God. Jehovah, when we arrive at our destinations, we shall not forget to say thank you. Be glorified, Lord, and be magnified that what you've not asked for, may the Holy Spirit continually intercede for us. In Jesus' name we ask and believe. Amen.